Hello and welcome to your ultimate guide for your CET exam. My goal today is give you everything that you need to understand the full concepts, master them, and walk you through the CET exam with total confidence. In this video we will cover regulatory compliance, infection control, clinical operations, safety procedures, professional boundaries. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website helps you to practice your CET exam with our practice questions, timed mock exams and study guides. You'll find the link in the description below. So let's get started.
Question 1. A technician learns that the vagus nerve is the major parasympathetic nerve to the heart and predominantly affects the SA and AV nodes. She wants to be able to name the cardiac effects of vagal stimulation. What effect does vagal stimulation typically have on the heart? Your options are A. Increases conduction velocity through the AV node. B. Increases the contractility of ventricular muscle. C. Slows the sinoatrial node firing rate. D. Increases the resting heart rate. Which one is it? Pause the video if you need more time. The correct answer is C. Slows the sinoatrial node firing rate. C is correct because vagal stimulation slows the sinoatrial node firing rate and delays atrioventricular conduction, decreasing heart rate. Parasympathetic tone normally counterbalances the SA node's higher intrinsic rate to keep the resting heart rate in the normal range. A is wrong because vagal stimulation slows AV node conduction rather than speeding it up. Sympathetic activity would speed conduction, while parasympathetic activity does the opposite at the AV node. B is wrong because parasympathetic effects on ventricular contractility are minimal, and the major effect on contractility is sympathetic. Vagal effects are concentrated on the SA and AV nodes rather than on ventricular muscle force. D is wrong because vagal activity decreases heart rate rather than increasing it. Increased resting heart rate is the sympathetic pattern, while increased vagal tone produces relative bradycardia. The vagus nerve is the parasympathetic pathway that runs from the brainstem down into the chest, placing fine branches directly onto the heart. Its fundamental job is to act as a brake, slowing the heart down rather than speeding it up. When the vagus fires, it releases acetylcholine onto two specific targets: the sinoatrial node, which sets heart rate, and the atrioventricular node, which controls conduction to the ventricles. Both nodes slow down as a result. The intrinsic SA node rate is around 100, some 110 beats per minute, but continuous vagal tone holds us well below that at rest. At the AV node, slowed conduction appears on the EKG as a longer PR interval. Crucially, ventricular contractility is barely touched, and no facamata. The vagus works on the nodes, not the working myocardium. On the certification exam, these are the signal words that point to vagal or parasympathetic activity. Any scenario pairing one of these triggers with the slowing of the heart is a vagal call. The opposite picture, rising rate or rising contractility, points to the sympathetic side, the dividing line that protects exam points. Parasympathetic activity meaningfully decreases rate only, while sympathetic activity increases both rate and contractile force. Questions about stroke volume or how hard the ventricle squeezes always point sympathetic. Questions about conduction speed or pause length always point parasympathetic. Question 2. A patient receives a Holter monitor and is told to keep a written diary during the recording period. The technician wants the patient to understand what kinds of entries make the diary most useful for the cardiologist. Which kind of entry is most important? Your options are A. Activities, symptoms, and the times. B. Daily weather and outdoor temperature. C. Brief notes about favorite meals. D. Sleep duration only, no other details. Take a second. Which answer would you pick? The correct answer is A. Activities, symptoms, and the times. A is correct because the diary's purpose is to correlate symptoms and activities with the rhythm strip. So entries should include what the patient was doing, what symptoms occurred, and the exact times they happened. This pairing helps interpret the tracing. B is wrong because weather and outdoor temperature are not part of the clinical correlation that the Holter diary supports. The cardiologist needs to know about the patient's activities and symptoms, not environmental conditions outside the patient's body. C is wrong because brief notes about favorite meals offer no actionable information unless the meals are linked to symptoms or activity that the patient also recorded. Notes about food preferences alone do not help correlation with the strip. D is wrong because sleep duration alone leaves out the symptom and activity content that makes the diary genuinely useful. Sleep is one valid entry but cannot be the only category for a useful Holter diary. A Holter monitor records a continuous EKG tracing over 24 to 48 hours while the patient lives their normal life. The diary worn alongside it is not a journal. It is a clinical timing tool designed to give the cardiologist the context the waveform alone cannot provide. The monitor captures every heartbeat, but on its own. The strip cannot tell the cardiologist what the patient was doing or feeling at any given moment. The diary bridges that gap by recording context at the exact time something noticeable occurs. Every diary entry must contain three things together: the exact time, a concrete description of the activity, like climbing stairs or drinking coffee, and any symptom the patient noticed, such as pounding, dizziness, or chest tightness. All three must appear in the same line for the cardiologist to draw a clinical conclusion. The common exam trap is confusing quantity of writing with quality of correlation. Weather, food preferences, and vague mood states produce no clinical signal. Only entries that pair a specific time, activity, and symptom allow the cardiologist to decide whether an abnormal beat and a symptom belong to the same event. Remember, the Holter diary exists solely to let the cardiologist match a moment on the tracing to what the patient was doing and feeling. Time, activity, and symptom together, that is the rule, and it is the only thing the diary needs to capture. Question 3. An elderly patient who lives alone arrives for an EKG and seems to need extra time to follow instructions. The technician should adapt without making assumptions about cognitive capacity. Which approach best matches communication with the older adult? Your options are: A. Speak louder by default for clarity. B. Use baby talk for warmth. C. Allow extra time and speak clearly. D. Skip explanation due to age. Before I reveal it, which one do you think is right? The correct answer is C. Allow extra time and speak clearly. C is correct because allowing extra time and speaking clearly without assuming cognitive impairment respects the patient as a competent adult who may need a slower pace. Patience and clarity together meet most older adults' communication needs effectively. A is wrong because speaking louder by default treats every older adult as if hearing impairment is universal. Many older patients hear normally, and added volume signals an assumption rather than an observation of the patient. B is wrong because using baby talk with adults of any age is condescending and undercuts dignity. Older patients have repeatedly identified terms like sweetie and honey as disrespectful when used by clinical staff during care. D is wrong because skipping the explanation reflects an ageist assumption that the patient cannot understand it. Every adult patient who has capacity is entitled to a clear explanation of what is about to happen during the test. When caring for older adults, the guiding principle is the same one that anchors every clinical interaction. treats the patient as a competent adult unless something specific in the encounter suggests otherwise. Elder speak, that sing-song, overly loud, simplified register, is often used reflexively with anyone over 65. Research shows it makes patients feel diminished, and it actually worsens performance on cognitive assessments because being treated as incompetent affects engagement. In practice, begin with normal volume and plain adult vocabulary. Allow extra time for questions and positioning. Sit at eye level and confirm understanding by asking the patient to repeat the next step back. Adapt only when the specific patient shows a specific need. The difference between assumption and adaptation is the core distinction exam writers test. Defaulting to loud speech, baby talk, or skipping explanations are reflex behaviors that look like consideration but are actually disrespectful shortcuts. The exam day signal is this: the correct approach always begins with normal adult communication and adapts only when the individual patient shows individual need. Respect and dignity are not extras, they are the baseline. Question 4. A technician is reading an EKG and notices that lead 1 shows an inverted P wave while AVR shows an upright P wave, both of which are abnormal. The QRS in lead 1 is also negative. What is the most likely cause of this pattern? Your options are A. Acute inferior wall myocardial infarction, B. Reversal of the right and left arm electrodes, C. Severe hypothermia with cardiac changes, D. Hyperkalemia affecting both atria. What's your answer? Commit to one before I continue. The correct answer is B. Reversal of the right and left arm electrodes. B is correct because an inverted P wave in lead 1 paired with an upright P wave in AVR is the classic pattern of right and left arm electrode reversal. Before assuming a clinical diagnosis, the technician should check electrode placement and re-record. A is wrong because acute inferior myocardial infarction produces ST elevation in leads 2, 3, and AVF rather than the specific arm reversal pattern in lead 1 and AVR. The inferior MI presentation does not match the described findings. C is wrong because severe hypothermia tends to produce Osborne or J waves and bradycardia rather than the inverted P pattern in lead 1. Hypothermia changes look very different from the reversal pattern described in the scenario. D is wrong because hyperkalemia produces peaked T waves and eventually wide QRS and sine wave patterns rather than inverted P waves in lead 1. The hyperkalemia pattern affects different waveforms than the ones described here. Lead I and AVR look at the heart from opposite directions, making them electrical mirrors of each other. Understanding this reciprocal relationship is the key to spotting one of the most common errors in EKG acquisition. In normal sinus rhythm, atrial depolarization travels from the SA node downward and to the left, toward the left arm. Because lead eye uses the left arm as its positive pole, this produces an upright P wave. Because AVR uses the right arm as its positive pole, that same wave moves away from it, inscribing an inverted P. When the right and left arm cables are swapped, every voltage in lead I flips. The telltale constellation is an inverted P in lead ER, an upright P in AVR, and a negative QRS in lead I, a mirror image of normal. The correct troubleshooting sequence is hardware first, physiology second. Ectopic atrial rhythm and junctional rhythm are real diagnoses, but a cable swap is far more common. Verifying electrode placement before invoking pathology is a defining habit of a competent EKG technician. On the certification exam, whenever you see an inverted P in lead I paired with an upright P in AVR, call electrode reversal until proven otherwise. Holding this habit prevents one of the most common false positive workups in cardiology. Question 5. A technician begins chest compressions on an adult patient in cardiac arrest after confirming unresponsiveness and absent pulse. She wants to perform compressions at the rate recommended by American Heart Association BLS guidelines. Which compression rate fits the adult standard? Your options are A. About 60 per minute slowly, B. About 80 per minute steadily, C. About 50 per minute carefully, D. About 100 to 120 per minute. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. About 100 to 120 per minute. D is correct because AHA guidelines call for adult chest compressions at 100 to 120 per minute to maximize forward blood flow during resuscitation. Slower or faster rates reduce the effectiveness of cardiac output during the arrest. A is wrong because 60 per minute is well below the recommended rate and does not produce enough cardiac output during cardiac arrest. Slow compressions allow the heart and brain to remain under-perfused throughout the resuscitation attempt. B is wrong because 80 per minute also falls short of the recommended floor of 100. While faster than 60, this rate still fails to generate the forward flow that the recommended range produces in practice. C is wrong because 50 per minute is so slow that it almost guarantees inadequate perfusion. Compressions this slow are sometimes seen with rescuer fatigue or hesitation and require immediate course correction by switching providers or coaching. Adult CPR guidelines set a specific compression rate range, and that range exists for a precise physiological reason, not as an arbitrary number. The American Heart Association targets 100 to 120 compressions per minute. Fall below and perfusion drops. Climb above and the heart has no time to refill between pushes. Both errors reduce survival equally. The chest wall acts as a mechanical pump. Each compression squeezes blood forward toward the brain and coronary arteries, and full recoil between pushes allows the heart to refill. Rate and depth together determine how much blood actually moves. In practice, providers use a counting cadence, a metronome, or a real-time monitor to stay in the target band. It's because fatigued compressors drift slow without noticing. Rotating compressors every 2 minutes preserves quality throughout a prolonged resuscitation. The compression rate is not the heart rate you are trying to restore. It is the cadence of the manual pump. Know the floor, know the ceiling, and keep the pump in range. Question 6. A technician reviews a tracing showing ST depression with a scooped or sagging appearance in multiple leads on a patient taking digoxin for atrial fibrillation. The patient is otherwise stable. Which finding does this pattern likely represent? Your options are A. Acute subendocardial ischemia, B. Severe hyperkalemia present, C. Digoxin effect on the EKG, D. Severe hyperkalemia from diuretics. Which would you go with? Lock it in before the reveal. The correct answer is C. Digoxin effect on the EKG. C is correct because digoxin effect produces a characteristic scooped or sagging ST depression, sometimes described as a Salvador Dali mustache pattern. This finding reflects the medication's expected EKG effect rather than ischemia or other pathology. A is wrong because acute subendocardial ischemia typically produces horizontal or down-sloping ST depression rather than the scooped digoxin pattern. The shape of the depression helps distinguish the two causes. B is wrong because severe hyperkalemia produces tall peaked T waves, prolonged PR, and wide QRS rather than scooped ST depression. The hyperkalemia pattern affects different waveforms entirely. D is wrong because hypokalemia produces flattened T waves, prominent U waves, and ST depression of a different character. Hypokalemic ST changes typically do not show the scooped digoxin morphology. Digoxin is a cardiac glycoside used for rate control in atrial fibrillation and for inotropic support in heart failure. Beyond its therapeutic effects, it produces a distinctive and expected change on the EKG that every technician needs to recognize. The hallmark is a downsloping, scooped ST depression with a concave upward curve, sometimes called the Salvador Dali moustache for its soft drooping shape. The T wave shortens and flattens, and the QT interval shortens as well. This pattern reflects how digoxin alters ventricular repolarization, not ischemia. Digoxin inhibits the sodium-potassium ATPase pump, which raises intracellular sodium. That slows the sodium-calcium exchanger, leaving more calcium inside the cell. The result is a stronger contraction, the inotropic effect, and altered repolarization that produces the characteristic scooped ST pattern. ST depression alone has 4 common causes: digoxin effect, ischemia, hypokalemia, and ventricular hypertrophy strain. The shape is what separates them. Digoxin produces a gentle concave upward curve. Ischemia produces a horizontal or sharply downsloping line. Hypokalemia is shallow and paired with prominent U waves. The critical distinction is digoxin effect versus digoxin toxicity. Effect means the scooped ST depression in a stable patient at therapeutic levels. Anxiety, completely expected and benign. Toxicity produces dangerous arrhythmias including accelerated junctional rhythms, ventricular bigamy, and bidirectional ventricular tachycardia, which is nearly pathognomonic for digoxin overdose. Question 7. A technician is counting an adult patient's respirations. The patient is alert and comfortable. The technician wants to obtain an accurate measurement without altering the patient's natural breathing pattern. Which technique best supports an accurate count? Your options are: A. Tell the patient she is counting breaths. B. Count without informing the patient. C. Ask the patient to breathe slowly. D. Hold the patient's chest still. Don't overthink it. Which one feels right? The correct answer is B. Count without informing the patient. B is correct because counting respirations without informing the patient prevents voluntary control from altering the rate, depth, or rhythm. Many technicians keep their fingers on the wrist as if still taking the pulse so the patient does not notice the shift. A is wrong because telling the patient you are about to count breaths invites voluntary control of breathing rate and depth. Conscious attention changes the pattern, which corrupts the very measurement the count was meant to capture. C is wrong because asking the patient to breathe slowly produces a deliberately altered rate rather than the patient's true resting respirations. The recorded number would reflect the request, not the patient's actual baseline breathing. D is wrong because holding the patient's chest still prevents normal breathing and may distress the patient. Physical restriction of the chest interferes with both the count and the patient's comfort during what should be a passive measurement. Measuring respiratory rate sounds simple, but the technique requires a deliberate deception, not to mislead the patient, but to protect the measurement itself. Breathing is unique among vital signs because it straddles automatic and voluntary control. The brainstem drives the resting rhythm, but the moment a patient becomes aware their breathing is being watched, the cortex takes over and the natural baseline disappears. 3 common mistakes each corrupt the rate in different ways. Announcing the count triggers conscious override. Asking the patient to breathe slowly actively prescribes a non-baseline pattern. Restricting the chest physically interferes with breathing itself. The correct technique is a small piece of theater. After taking the pulse, the technician keeps fingers on the wrist and quietly shifts focus to the chest. To the patient, nothing has changed, and that unawareness is exactly what preserves the true baseline. When the patient is unaware, The brainstem stays in control and the recorded number reflects actual physiology. Explaining the measurement defeats it. The technique earns its value precisely because nothing is said. Question 8. A technician examines an EKG and notices the precordial R waves do not progress normally from V1 to V6, with persistent S waves in V5 and V6. She considers whether the electrodes were placed too high. What does poor R wave progression often suggest? Your options are A. The patient has perfect normal anatomy. B. The gain has been set too high. C. Prior anterior MI or chest electrode placement too high. D. The room has heavy electromagnetic interference. Got a guess? Lock it in. The correct answer is C. Prior anterior MI or chest electrode placement too high. C is correct because poor R wave progression with persistent S waves in V5 and V6 often suggests prior anterior wall myocardial infarction or technical error from placing chest electrodes too high on the chest. Verifying placement is the first troubleshooting step. A is wrong because normal anatomy produces progressive R wave growth from V1 to V5 or V6, with a transition zone around V3 or V4. Persistent S waves in V5 and V6 do not match the normal progression pattern. B is wrong because gain set too high would amplify all signals proportionally rather than altering the R wave progression specifically. Gain effects are systemic across the tracing and do not produce regional progression problems. D is wrong because electromagnetic interference appears as a regular sine wave overlay on the entire tracing rather than as a specific R wave progression pattern. Interference looks different from a progression abnormality. R wave progression describes the orderly growth of the R wave across the 6 precordial leads from V1 to V6. Understanding why this pattern exists and what breaks it is essential for any EKG technician. The precordial leads view the heart from progressively leftward positions. At V1, the right side dominates, small r, deep S. As the leads sweep toward V6 at the left axillary line, more of the left ventricle's mass comes into view, and the R wave grows steadily too much. The transition zone, where R and S are roughly equal, normally falls around V3 or V4. Poor R wave progression is recognized by 3 features: R waves that fail to grow across the chest leads, prominent S waves that persist all the way into V5 and V6, and a transition zone that is absent or shifted abnormally far to the left. Any of these should prompt the technician to investigate the cause. There are 4 main causes to know: prior anterior MI, where scar tissue generates no depolarization vector; high lead placement, where electrodes sit too far up the chest and mimic poor progression in a normal heart; left ventricular hypertrophy; and COPD with a rotated heart position. Crucially, the technician must rule out the technical cause, lead placement, before the cardiologist can invoke a clinical one. The key discipline is order of suspicion. Check electrode placement first, then consider prior MI, then other structural causes. Poor R wave progression is a finding with a differential, not a single diagnosis, and the technician who knows that distinction will earn the points on exam day. Question 9. A technician needs to place V4 on a patient and reviews the landmark before applying the electrode. V4 serves as the reference horizontal level for V5 and V6. Where on the chest should V4 be placed? Your options are A. 4th intercostal space right of sternum, B. 4th intercostal space left of sternum, C. 5th intercostal space mid-axillary line, D. 5th intercostal space mid-clavicular line. Which one is it? Pause the video if you need more time. The correct answer is D. 5th intercostal space mid-clavicular line. D is correct because V4 is placed at the fifth intercostal space on the left mid-clavicular line. The horizontal level set by V4 becomes the reference plane for V5 and V6 in the anterior, axillary and mid-axillary lines. A is wrong because the fourth intercostal space to the right of the sternum is the V1 location. That position is far from V4's level and on the wrong side of the chest for V4. B is wrong because the fourth intercostal space to the left of the sternum is V2, not V4. V2 is one intercostal space higher and considerably more medial than V4's location. C is wrong because the fifth intercostal space at the mid-axillary line is the V6 position rather than V4. Lateral chest placement at the mid-axillary line is reserved for the far lateral precordial lead. The precordial leads were designed in the 1930s to view the heart from specific anatomic angles. Reproducibility depends on every technician hitting the exact same landmarks, and V4 is the anchor for the entire left-sided array. V1 and V2 sit in the fourth intercostal space on either side of the sternum. V4 drops one space lower to the fifth intercostal space, aligned with the left mid-clavicular line. V3 sits diagonally between them, and V5 and V6 follow V4's horizontal line out toward the axilla. In practice, you palpate the sternal angle of Louis to find the second rib. Count down intercostal spaces to the fifth. Then drop a vertical line from the midpoint of the left clavicle. Where that line meets the fifth intercostal space is exactly where V4 belongs. Because V5 and V6 follow V4's horizontal level rather than the fourth space line, one misplaced electrode shifts the entire lateral view. Consistent landmark use is what makes serial comparison between two EKGs from the same patient meaningful. When you see the signal words fifth intercostal space and left mid-clavicular line together, that is V4. Holding the full geometric pattern, two horizontal levels with a diagonal bridge, keeps every precordial lead in its correct position. Question 10. A technician learns about the relative refractory period, during which a stronger than normal stimulus can trigger an action potential. She knows that an early extra beat landing in this period can be dangerous. Which segment corresponds to the relative refractory period and R on T risk? Your options are A. The PR segment after the P. B. The TP segment between beats. C. The T wave, especially its peak. D. The QRS complex itself. Take a second. Which answer would you pick? The correct answer is C. The T wave, especially its peak. C is correct because the relative refractory period corresponds roughly to the T wave on the EKG, with the peak being particularly vulnerable. A premature ventricular complex landing on the T wave is the classic R on T phenomenon that can trigger ventricular tachycardia. A is wrong because the PR segment falls between atrial and ventricular activation and is not the ventricular relative refractory window. PR segment timing does not match the T-wave vulnerable period under discussion. B is wrong because the TP segment lies between beats when the heart is at rest, well past any refractory period. R on T cannot occur during the resting interval because there is no vulnerable repolarization gradient there. D is wrong because the QRS complex corresponds to the absolute refractory period rather than the relative one. A stimulus during the QRS cannot trigger a new action potential at all, which is the opposite of relative refractoriness. After a cardiac cell fires, it doesn't snap back to full excitability instantly. Recovery happens in two distinct stages, and understanding the second stage, the relative refractory period, is essential for explaining dangerous arrhythmias. The absolute refractory period comes first. No stimulus of any strength can fire the cell because sodium channels are fully inactivated. The relative refractory period follows. when a growing fraction of channels have reset and a stronger than normal stimulus can still trigger depolarization. On the action potential curve, the relative refractory period occupies the downslope of repolarization on the surface EKG. This maps to the T wave, and critically, the peak of the T wave marks the most vulnerable point of partial recovery. This is the R-on-T phenomenon. A premature ventricular contraction that lands on the T wave peak hits the cell at peak vulnerability. The result can be ventricular tachycardia or ventricular fibrillation, which is exactly why pacemakers and defibrillators use sensing circuits to avoid delivering energy during this window. On exam day, the signal words are stronger stimulus, vulnerable period, T wave peak, R-on-T, and partial recovery. Remember, the absolute period rejects all stimuli, the relative period accepts strong ones, and that distinction can be life or death in clinical cardiology. Question 11. A technician is performing a 12-lead EKG on a patient with a known pacemaker in the upper left chest. She needs to place chest electrodes without compromising the device or the tracing. What consideration applies to chest electrode placement near the pacemaker? Your options are A. Place electrodes directly over the device. B. Avoid placing electrodes directly over the pulse generator. C. Skip the chest leads entirely. D. Place all chest leads on the right side. Before I reveal it, which one do you think is right? The correct answer is B. Avoid placing electrodes directly over the pulse generator. B is correct because chest electrodes should not be placed directly over the pulse generator of an implanted pacemaker because the device interferes with gel skin contact and signal quality. The electrode should be shifted to a position adjacent to the device. A is wrong because placing electrodes directly over the device degrades both the signal quality and the adhesion. Going on top of an implant is the exact placement to avoid in pacemaker patients. C is wrong because skipping the chest leads entirely leaves the 12-lead EKG incomplete and removes the precordial views needed for a full interpretation. A small placement adjustment lets the test proceed normally. D is wrong because placing all chest leads on the right side would convert them into right-sided leads rather than the standard precordials. Such relocation changes the lead's clinical meaning entirely. When a patient has an implanted pacemaker, standard chest lead placement has to be modified, but only just enough to avoid the device. Understanding why starts with how the pulse generator disrupts the signal path. The pulse generator sits between the heart and the skin, and because metal conducts electricity poorly through tissue in this context, any electrode placed directly over it picks up artifact rather than true cardiac signal. The device physically distorts the voltage path from heart to skin. Placing an electrode on top of the pulse generator causes 3 problems: artifact, corrupting the tracing, distorted QRS morphology, and in rare cases, a short circuit between the device's surface and the recording lead. None of these outcomes support accurate diagnosis. The discipline is a minimal lateral shift to clear the generator while staying in the same intercostal space. Moving vertically changes every comparison with prior tracings, and skipping the lead entirely eliminates that region's cardiac view. The goal is the smallest deviation that clears the device. On certification exams, the signal words are pacemaker pocket, upper left chest, and standard placement modified. The correct answer is always a small lateral shift to clear the generator, not a vertical move, not a skipped lead. Question 12. A technician is asked to record posterior leads V7, V8, and V9 for a patient with suspected posterior wall MR. She wants to know the standard horizontal level for these leads. At what level should the posterior leads be placed? Your options are A. At the level of the second intercostal space. B. Below the diaphragm in the abdomen. C. At the level of the clavicles in the back. D. At the same horizontal level as V6. What's your answer? Commit to one before I continue. The correct answer is D. At the same horizontal level as V6. D is correct because V7, V8, and V9 are placed at the same horizontal level as V6, with V7 on the posterior axillary line, V8 on the midscapular line, and V9 on the paraspinal area. The horizontal level stays constant. A is wrong because the second intercostal space level is far above the posterior wall view that V7 through V9 are meant to provide. Placing them that high would not reach the posterior territory of the left ventricle. B is wrong because placing electrodes below the diaphragm in the abdomen leaves the heart entirely. Abdominal placement records nothing useful about cardiac electrical activity, particularly for posterior wall evaluation. C is wrong because the clavicle level on the back is well above the cardiac silhouette in most adults. Placing posterior leads that high would miss the posterior heart territory the leads are meant to image. When a posterior wall myocardial infarction is suspected, the standard 12-lead EKG falls short. It views the heart from the front and misses the posterior left ventricle almost entirely. That's where posterior leads come in. A true posterior infarction doesn't show ST elevation on the standard leads. Instead, it produces reciprocal changes, tall R waves, and ST depression in V1 and V2. Adding V7, V8, and V9 captures direct ST elevation from the posterior wall, turning an indirect suspicion into a confirmed diagnosis. The placement rule is elegantly simple. All 6 leads, V4 through V9, share the same horizontal level, the fifth intercostal space. V7 sits at the posterior axillary line, V8 at the midscapular line, and V9 just lateral to the spine. The lateral position changes, the horizontal level never does. The critical exam insight is this: the level is fixed, the lateral position is not. Students who shift the posterior leads to a lower intercostal space break the correlation with V6 and produce a tracing that represents a different cut through the heart entirely. Hold the horizontal line and every posterior lead scenario becomes straightforward. Whenever you see V7, V8, or V9 on an exam, anchor your answer to one principle: same horizontal level as V6, extended around the back. That geometric simplicity is the rule, and it's the correct answer every time. Question 13. A technician sees Q waves on a tracing that are wider than 0.04 seconds and deeper than 25% of the R wave amplitude in 2 contiguous leads. The patient is asymptomatic. Which interpretation fits this finding? Your options are A. Acute ST elevation myocardial infarction. B. Active ischemia without infarction. C. Prior or completed myocardial infarction. D. Normal physiologic variant. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Prior or completed myocardial infarction. C is correct because pathologic Q waves wider than 0.04 seconds or deeper than 25% of the R wave in 2 contiguous leads indicate prior or completed infarction. Q waves typically develop hours to days after an acute event. A is wrong because acute ST elevation infarction features ST elevation as its hallmark rather than pathologic Q waves alone. Q waves appear later after the acute phase has resolved. B is wrong because active ischemia typically shows ST depression or T wave inversion rather than pathologic Q waves. Q waves represent scar tissue from completed infarction, not active reversible ischemia. D is wrong because normal physiologic Q waves are small and narrow, not pathologic. The criteria described specifically distinguish pathologic Q waves from normal variants. Pathological Q waves are the EKG signature of dead myocardial tissue. Understanding what makes a Q wave pathological, rather than normal, is the key clinical skill being tested here. A Q wave becomes pathological when it exceeds two size thresholds, wider than 0.04 seconds and deeper than 25% of the Auge wave that follows it. Critically, this pattern must appear across contiguous leads in the same coronary territory, not in a single isolated lead. Dead myocardium produces no depolarization vector. When scar tissue replaces a section of ventricular wall, any lead looking at that region records only electrical silence, which appears as a downward deflection at the start of the QRS, the Q wave itself. The wider and deeper it is, the larger the scar. Q waves develop predictably after a heart attack. In the first hours, ST elevation dominates. Over the next day, pathological Q waves begin to form as scar tissue sets. Within weeks, the ST segment normalizes, but the Q waves remain permanently, a lasting EKG record of the historic infarction. When a Q wave is wide, deep, and appears across contiguous leads of the same coronary territory, it marks completed infarction. A single small Q wave may be normal. It takes all three criteria together to confirm the diagnosis. Question 14. A technician removes her gown after a contact precautions visit and wants to dispose of the gown without spreading any contamination onto her uniform underneath. Which technique is most consistent with safe gown removal practice during the doffing sequence? Your options are: A. Pull it forward by the chest. B. Hand it directly to a co-worker. C. Fold the outside surface against itself. D. Unfasten, peel from shoulders, roll inside out. Which would you go with? Lock it in before the reveal. The correct answer is D. Unfasten, peel from shoulders, roll inside out. D is correct because safe gown removal involves unfastening the ties, peeling the gown away from the neck and shoulders, and rolling it inside out so the contaminated outer surface is contained inside the bundle for disposal in the appropriate bin. A is wrong because pulling forward by the chest places the technician's hand on the most contaminated outer surface of the gown. Touching the front transfers organisms back onto the hand and onto whatever the hand touches next. B is wrong because handing the contaminated gown to a co-worker spreads the exposure rather than containing it within disposal. The handoff creates a brand new chain of contamination that started inside the patient's room. C is wrong because folding the outside surface against itself without first unfastening the ties tangles the gown and concentrates contamination at the point where the technician must grip to finish removal. The unfasten step belongs first in the sequence. After a contact precautions visit, the outer surface of your isolation gown is contaminated. Removing it carelessly can transfer organisms to your skin, your scrubs, or the surrounding environment. The doffing technique exists specifically to prevent that transfer. Contact precautions exist because certain organisms, MRSA, Clostridioides difficile, VRE, and drug-resistant gram-negatives, survive on gown surfaces and can be inoculated onto the next patient or onto the clinician if the gown is removed carelessly. The correct sequence has 3 steps. Unfasten the neck and waist ties first, grasp the shoulders from the inside and peel the gown forward. Then roll it inside out as it comes off the arms. Each step in that order serves a specific purpose. As the gown peels forward off the shoulders, the dirty outer surface folds inward and the clean inner surface ends up on the outside of the bundle. The bundle drops directly into a receptacle, never set on another surface, and hand hygiene follows immediately. The key is treating gown removal as a contamination control procedure, not like taking off a regular shirt. remember, unfasten first, peel from the shoulders, and roll inside out so the dirty side stays balled inside the bundle. Question 15. A technician arrives to find a patient room marked with droplet precautions for influenza. The patient is alert and tolerating bed rest well. The technician is about to enter. What PPE step is specifically required for droplet precautions in this scenario? Your options are A. N95 respirator with annual fit test. B. Surgical mask within close range. C. Gown only for body contact. D. Full-powered air purifying respirator. Don't overthink it. Which one feels right? The correct answer is B. Surgical mask within close range. B is correct because droplet precautions call for a surgical mask within 6 feet of the patient or upon room entry because large respiratory droplets travel short distances. A surgical mask blocks those droplets without requiring the higher protection a fit-tested respirator provides. A is wrong because an N95 respirator with annual fit testing is reserved for airborne precautions with small particle nuclei. Influenza droplets are larger and fall to the ground quickly, making a surgical mask the matched choice. C is wrong because gowning alone does nothing to block droplets that land on the technician's mouth, nose, or eyes during patient care. A gown without a mask leaves the very pathway that droplets use to spread between people. D is wrong because a powered air purifying respirator is reserved for high-risk procedures or when respirator fit fails. Pulling the highest level of protection for routine droplet care wastes resources and adds bulk to the visit. Droplet precautions are a specific infection control category designed for pathogens that spread through large respiratory droplets. Understanding why they differ from airborne precautions and what equipment they actually require is the key to mastering this topic. Common droplet spread pathogens include influenza, pertussis, mumps, rubella, and many bacterial respiratory infections. What they share is transmission via large particles that travel no more than 3 to 6 feet before falling to the floor. The physics explain the precaution. Large droplets are heavy. They arc downward and hit the floor within 3 to 6 feet. Tiny droplet nuclei, like those carrying tuberculosis or measles, stay suspended in the air for hours and can drift across an entire room. For droplet precautions, the clinician performs hand hygiene before entering, then dons a surgical mask before coming within 3 to 6 feet of the patient. Eye protection is added only when procedures risk aerosolizing secretions. Routine bedside care requires the mask alone, not an N95 respirator. The certification exam rewards one discipline, pairing the right barrier to the right route of transmission. A surgical mask is sufficient and correct for droplet spread infections. Reaching for an N95 for influenza wastes critical resources without adding meaningful protection. Question 16. A technician sees a strip with a regular wide QRS rhythm at 60 beats per minute, no P waves, after a patient just received thrombolytic therapy for acute MI. The rate is between idioventricular and accelerated ranges. Which rhythm fits this picture? Your options are A. Sinus tachycardia with bundle block. B. Atrial fibrillation with rapid response. C. Accelerated idioventricular rhythm reperfusion pattern. D. Sinus bradycardia at very slow rate. Got a guess? Lock it in. The correct answer is C. Accelerated idioventricular rhythm reperfusion pattern. C is correct because accelerated idioventricular rhythm at 40 to 100 beats per minute is a classic post-thrombolysis reperfusion rhythm that is usually transient and well tolerated. The wide QRS reflects ventricular origin while the rate sits above pure idioventricular escape. A is wrong because sinus tachycardia with bundle block would still show P waves before each QRS. The absence of P waves rules out sinus origin for this rhythm. B is wrong because atrial fibrillation is irregularly irregular without organized P waves. The regular wide complex rhythm described does not match fibrillation despite the absent P waves. D is wrong because sinus bradycardia uses the SA node with upright P waves before narrow QRS complexes. Wide QRS without P waves rules out sinus origin. Accelerated idioventricular rhythm, or AIVR, is a wide QRS rhythm arising from a ventricular pacemaker rather than the sinus node. Understanding it means knowing exactly where it sits on the rate spectrum and why it appears. Rate is the critical discriminator. Idioventricular escape runs below 40 beats per minute, ventricular tachycardia above 100, and AIVR occupies the middle range, roughly 40 to 120, with a wide, regular QRS throughout. During ischemia, myocardial cells lose normal membrane function and go electrically silent. When blood flow is restored, those cells begin firing again. Some become temporarily ectopic, conducting slowly through ventricular muscle rather than the fast His-Purkinje system, which is exactly why the QRS is wide. After thrombolysis or PCER, AIVR typically appears within minutes, lasts seconds to a few minutes, and resolves on its own. Treatment is not needed. The rhythm is a reassuring signal that reperfusion is working, and suppressing it with antiarrhythmics provides no benefit. The exam takeaway is straightforward. A regular wide complex rhythm near 60 in a post-thrombolytic patient is AIVR, not ventricular tachycardia. Hold the rate and the clinical context together and the call is always correct. Question 17. A technician sees a patient with unstable supraventricular tachycardia at 190 beats per minute who is conscious, hypertensive, and reports chest pain. The clinician decides intervention is needed. Which intervention is appropriate for unstable SVT with a pulse? Your options are A. Independent technician defibrillation, B. Watchful waiting with observation only, C. Routine assistal treatment with epinephrine, D. Synchronized cardioversion by the clinician. Which one is it? Pause the video if you need more time. The correct answer is D. Synchronized cardioversion by the clinician. D is correct because unstable supraventricular tachycardia with a pulse and signs of poor perfusion is treated with synchronized cardioversion by the supervising clinician. Synchronization with the R wave avoids delivering the shock during the vulnerable T wave period. A is wrong because technicians do not independently deliver manual defibrillation or cardioversion, and the action requires a clinician's direction. Independent shocks are outside scope of practice. B is wrong because watchful waiting in an unstable patient ignores the immediate signs of poor perfusion. Unstable rhythms with chest pain and hypertension require active intervention, not observation. C is wrong because assistal treatment is for non-shockable flatline rhythms, not for tachycardias with a pulse. Applying asystole protocols to SVT would be inappropriate and ineffective. Synchronized cardioversion is a timed electrical shock used to convert a fast, organized arrhythmia back to normal sinus rhythm. The key word is synchronized. The device times its energy delivery to coincide with a specific moment in the cardiac cycle. The device fires on the R wave, not randomly, because delivering energy during the T wave would hit the vulnerable phase of repolarization, which can trigger ventricular fibrillation. Syncing to the R wave makes the shock safe and effective. Synchronized cardioversion is used for unstable but conscious patients with organized fast rhythms, supraventricular tachycardia, atrial fibrillation with rapid ventricular response, atrial flutter, and stable monomorphic ventricular tachycardia. These rhythms all have a discernible R wave to sync to. On the exam, scope of practice is heavily tested. The technician prepares the patient, applies pads, confirms the sync marker is on every R wave, and documents the tracings. The decision to cardiovert and the act of delivering the shock belong entirely to the clinician. Never confuse synchronized cardioversion with unsynchronized defibrillation. Defibrillation is used for ventricular fibrillation and pulseless ventricular tachycardia. Rhythms with no R wave to sync to. If the patient is unstable but conscious with an organized rhythm, synchronized cardioversion is the answer. Question 18. A technician records an adult patient's blood pressure manually. The cuff sits over the patient's sleeve because the patient asked to stay covered. The technician later realizes this likely affected the reading. Which error did the technician introduce by this choice? Your options are: A. Cuff over clothing causes inaccurate reading. B. Cuff size error producing false high. C. Patient talking during the measurement. D. Arm position above the heart level. Take a second. Which answer would you pick? The correct answer is A. Cuff over clothing causes inaccurate reading. A is correct because placing the cuff over clothing introduces an unpredictable layer between the bladder and the arm, which distorts pressure transmission and can shift readings either direction. The cuff should be placed on a bare upper arm for accurate manual measurement. B is wrong because the error described is a placement issue rather than a sizing problem. The cuff may be correctly sized while still being applied over a sleeve, so the source of the inaccuracy is different. C is wrong because the scenario makes no mention of the patient talking and centers entirely on the cuff being over the clothing. The talking error exists in practice but does not match the conditions described in this scenario. D is wrong because nothing in the scenario indicates the arm was held above the heart. While arm position errors do affect readings, they are not the source of inaccuracy that this scenario specifically created. Manual blood pressure measurement depends on the cuff transmitting pressure cleanly through bare skin to the brachial artery. Any clothing between the cuff and skin disrupts that transmission and shifts the recorded numbers away from the patient's true arterial pressure. The cuff wraps snugly around bare skin 2 to 3 centimeters above the antecubital fossa. The stethoscope sits over the brachial artery just below the cuff, and the technician listens for Korotkov sounds as pressure slowly releases. A sleeve or sweater introduces variable resistance that dampens the cuff's pressure signal. The resulting numbers can read falsely high or falsely low, and the drift is inconsistent, meaning the technician has no reliable way to correct it. When a patient asks to stay clothed, the correct response is not to cuff over the sleeve. Instead, the technician can slip the arm from the sleeve, switch to the other already exposed arm, or drape the shoulder for warmth while keeping the cuff arm bare. Accurate blood pressure measurement always requires bare skin under the cuff. The technician's job is to find a creative solution that respects the patient's comfort without ever accepting a reading taken over clothing. Question 19. A technician is reviewing a tracing with slow, undulating baseline drift that moves the entire complex up and down over several seconds. The patient is calm and breathing comfortably during the recording. Which artifact pattern fits the slow drift description best? Your options are A. AC interference at 60 Hz, B. Somatic tremor from cold patient, C. Broken lead wire producing chaos, D. Wandering baseline from electrode or respiration. Before I reveal it, which one do you think is right? The correct answer is D. Wandering baseline from electrode or respiration. D is correct because wandering baseline is the slow drift of the entire tracing up and down over time. typically caused by patient respiration, loose electrodes, dry electrode gel, or skin oils. Re-prepping the skin and replacing electrodes often resolves the drift. A is wrong because AC interference appears as fine, regular, high-frequency oscillations rather than a slow, undulating drift. The two patterns have different frequencies and different causes entirely. B is wrong because somatic tremor produces jagged, irregular high-frequency activity from muscle contraction rather than slow baseline drift. Tremor and drift look distinctly different on the tracing. C is wrong because a broken lead wire produces sudden bursts of noise or a flat segment on a single lead rather than a generalized slow drift. Broken wire artifacts are localized to one lead, not systemic. Wandering baseline is a slow, smooth undulation of the entire EKG tracing. The complexes drift up and down over several seconds, not as fast noise, but as a gradual wave. Understanding why it happens and how to fix it is what exam writers are testing. The key visual feature is that the cardiac signal is still present and recognizable, but the entire baseline shifts slowly up and down, like the tracing itself is breathing. This distinguishes it from other artifacts. Both root causes are technical. Loose or poorly contacted electrodes, like from dried gel, sweat, or hair, shifts the recording circuit geometry. Deep or labored respiration physically moves the chest wall and electrode positions with every breath. Always start with the electrodes. Look for lifting edges, dried gel, or unsecured lead wires. Re-prep the skin by cleaning, drying, and lightly abrading, then apply a fresh electrode. Only if the drift persists do you consider the patient's breathing pattern as the primary cause. Recognizing the pattern locks in the diagnosis. Wandering baseline is slow and smooth. 60-cycle interference is a rapid, regular sine wave from electrical mains. Muscle tremor is fast and jagged. The rate and shape of the disturbance always point to the cause and to the fix. Question 20. A technician needs to convey to a physician that a patient just had a syncopal episode during a stress test with documented hypertension and a brief rhythm change. The technician wants to structure the call efficiently. In SPA, which letter holds the technician's professional impression? Your options are A, the letter S for situation, B, the letter B for background, C, the letter A for assessment, D, the letter R for recommendation. What's your answer? Commit to one before I continue. The correct answer is C. The letter A for assessment. C is correct because the letter A in SBA stands for assessment, the technician's professional impression of what may be happening. This part of the report says what the technician thinks, framed against the situation and background already given. A is wrong because the letter S identifies the situation, which is the opening statement of who and what. Situation precedes the impression and frames the call rather than carrying the impression itself. B is wrong because the letter B presents background, the prior history and context relevant to the current report. Background gives the listener context, but does not capture the technician's professional impression of what is occurring. D is wrong because the letter R presents recommendation, the requested action or plan moving forward. Recommendation closes the report and follows the impression, but does not contain the impression itself. SBAR is a structured communication framework that helps healthcare providers convey critical patient information quickly and clearly. Originally borrowed from the US Navy's Nuclear Submarine Service, hospitals adopted it in the late 1990s to reduce errors during patient handoffs. Each letter carries a specific job. Situation is the headline, who the patient is and what just happened. Background is the relevant prior history. Assessment is the speaker's own clinical impression. Recommendation is the explicit ask, what the speaker wants the receiver to do. The critical distinction is between background and assessment. Background is established history, prior conditions, medications, and course. Assessment is the speaker's real-time clinical judgment about what the new data means. Conflating the two forces the receiver to hunt for the interpretation inside the history. Picture a stress lab technician calling a physician after a patient loses consciousness on the treadmill. She states the situation, gives the relevant cardiac history, then offers her clinical impression, exertional ventricular tachycardia with possible ischemia, before asking the physician to come immediately. That impression is the assessment. On exam day, the signal words for SABAR assessment are clinical impression, interpretation, and what the speaker thinks is happening right now. The letter A is never the patient's background and never the receiver's eventual diagnosis. It is the speaker's read of the moment, expressed as a clinical judgment. Question 20. A technician sees ST elevation greater than 1 millimeter in leads 2. 3. An AVF on a patient with chest pain. The patient is hypertensive. Which additional lead set should be considered to evaluate the right ventricle? Your options are A. Right-sided leads such as V4R. B. Posterior leads V7 through V9. C. The Lewis lead for P-wave clarity. D. Repeat the same standard 12 lead. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Right-sided leads such as V4R. A is correct because inferior MI may involve the right ventricle, especially when hypertension suggests RV failure. Right-sided leads such as V4R should be obtained because ST elevation, there is the key indicator of right ventricular infarction. B is wrong because posterior leads V7 through V9 evaluate the posterior wall rather than the right ventricle. Posterior wall evaluation is useful, but does not address the RV question raised by the clinical picture. C is wrong because the Lewis lead enhances P-wave visibility for atrial rhythm analysis and is not used to evaluate the right ventricle. The clinical question here is about RV involvement, not atrial activity. D is wrong because repeating the same standard 12 lead provides no additional information about the right ventricle. Additional dedicated leads are needed to look at the territory the standard leads do not view. When an inferior wall MI is suspected, the standard 12 lead EKG tells only part of the story. The right ventricle remains largely invisible unless we deliberately look for it using right-sided leads. Right-sided leads mirror the standard precordial leads but are placed on the right chest. V4R is the most diagnostically critical. Xiphocytes positioned at the fifth intercostal space in the right mid-clavicular line. V5R and V6R extend along the same horizontal level toward the right axilla. The right coronary artery supplies both the inferior left ventricular wall and most of the right ventricle. A proximal RCA occlusion injures both territories at once, but standard leads only reveal inferior ST changes. The right ventricle stays hidden without right-sided leads. The exam critical pattern is hypotension combined with inferior ST elevation. This pairing demands right-sided leads immediately. ST elevation in V4R then confirms right ventricular involvement and changes management entirely. Waktuan, fluids are given and nitroglycerin is withheld. The opposite of routine care. When you see inferior ST elevation with hemodynamic compromise, reach for right-sided leads. V4R is your headline finding. That single pairing, hypertension plus inferior MI, is the trigger that earns the correct answer on certification tests. Question 22. A technician is reviewing the normal conduction pathway and wants to identify the structure responsible for the brief delay between atrial and ventricular contraction. She knows this delay allows the ventricles to fill before contraction. Which structure produces this delay? Your options are A. The bundle of his in the septum. B. The Purkinje fibers in the ventricles. C. The right bundle branch. D. The atrioventricular node. Which would you go with? Lock it in before the reveal. The correct answer is D. The atrioventricular node. D is correct because the atrioventricular node delays the electrical impulse by about 1/10 of a second between atrial and ventricular activation. This pause allows the ventricles to fill from atrial contraction before the ventricles themselves contract. A is wrong because the bundle of His conducts the impulse rapidly from the AV node into the ventricular septum without adding the deliberate delay. Conduction through the bundle is fast rather than slow. B is wrong because Purkinje fibers distribute the impulse rapidly throughout the ventricular myocardium. Their conduction is among the fastest in the heart and is the opposite of a delay-producing structure. C is wrong because the right bundle branch carries the impulse rapidly through the right ventricle after the AV node has already added the delay. Bundle branches conduct quickly to enable coordinated ventricular contraction. The atrioventricular node sits at the junction between the atria and ventricles, and its defining job is to slow the electrical impulse before passing it on. Understanding why that delay exists and how it is produced is what ties the EKG to the mechanics of the beating heart. The impulse originates at the sinoatrial node, travels through atrial tissue, and arrives at the atrioventricular node. Only after the AV node releases the signal does it continue through the bundle of His. The bundle branches in the Purkinje fibers into the ventricular muscle. The 1/10 of a second pause is not a flaw at Z. It is a feature. It gives the atria time to finish contracting and push their final volume of blood into the ventricles before ventricular contraction begins. Without the pause, the two chambers would fire simultaneously and stroke volume would fall sharply. The delay is built into the cells themselves. AV nodal tissue lacks the fast sodium channels that make other cardiac cells conduct quickly, and instead relies on a slow calcium current. This drops conduction velocity dramatically, and that sluggish propagation is exactly what stretches out the PR interval you see on the surface EKG. The exam critical distinction is that only the AV node produces a meaningful pause. The sinoatrial node starts the impulse but does not slow it. The bundle of His, the bundle branches, and the Purkinje fibers all conduct at high speed. The AV node alone is built to delay, and it alone accounts for the PR interval. Question 23. A technician must perform an EKG on a patient with a right above the elbow amputation. She wonders where to place the right arm electrode given the missing limb. What is the standard approach for limb electrode placement on an amputee? Your options are A. Skip the right arm lead entirely. B. Place electrode on the left arm twice. C. Place on the stump close to the trunk. D. Place electrode on the patient's right ear. Don't overthink it. Which one feels right? The correct answer is C. Place on the stump close to the trunk. C is correct because for amputees, the limb electrode is placed on the stump as close to the trunk as possible, or on the corresponding shoulder if the entire limb is missing. The technician should document the deviation for the interpreter. A is wrong because skipping the right arm lead leaves an incomplete tracing, missing both lead 1 and the augmented voltage right arm view. Incomplete data forces the interpreter to work with less than the standard set. B is wrong because placing the electrode on the left arm twice would not produce the right arm signal needed for the standard limb leads. Duplicating one limb does not substitute for measurements from the missing side. D is wrong because the right ear is not an accepted limb electrode position and would produce wildly different recordings from the standard. Ad hoc placement at the head invents data that does not match accepted EKG conventions. When a patient has a limb amputation, the EKG electrode still needs to be placed somewhere, and where you put it matters enormously for the accuracy of the tracing. The 12-lead EKG calculates limb leads from voltage differences between 4 electrodes. Each electrode has an assumed anatomic position based on the Einthoven triangle model. Shifting an electrode away from that position rotates the lead axis and alters how the tracing looks. The rule is straightforward. Place the electrode on the residual stump as close to the trunk as possible. For above the elbow amputation, that means near the shoulder. Never place it on the opposite limb. That corrupts the lead axis entirely. For a right above the elbow amputation, the electrode is placed on the upper portion of the stump, close to the shoulder. This keeps the lead axis geometry as close to its original position as the patient's anatomy allows, producing a tracing comparable to one from an intact limb. On the certification exam, always choose the residual stump over the trunk, and never skip the lead or swap to the opposite limb. The closer the electrode stays to its expected position, the more reliable and comparable the tracing. Question 24. A technician finds a sign on a patient's door requiring airborne precautions for active tuberculosis. The technician must enter to perform an EKG. Which combination of room conditions and personal protection most accurately fits airborne precautions? Your options are A. Negative pressure room and fitted N95. B. Positive pressure room and surgical mask. C. Standard room and contact gown only. D. Cohort room and routine gloves only. Got a guess? Lock it in. The correct answer is A. Negative pressure room and fitted N95. A is correct because tuberculosis spreads on small particle nuclei that stay suspended in air. So airborne precautions require a negative pressure airborne infection, isolation room and a fit tested N95 respirator for every person who enters. Both conditions together protect against inhalation. B is wrong because positive pressure rooms push air outward and are used for the reverse purpose of protecting an immunocompromised patient from the environment. Using positive pressure for tuberculosis would push infectious air toward the hallway and worsen exposure. C is wrong because a standard room without negative pressure allows airborne particles to escape into corridors and other patient areas. A contact gown also addresses physical surface transmission, not the inhalation pathway tuberculosis uses to spread between people. D is wrong because cohort rooms group similar contact precaution patients, while gloves alone protect only against surface transfer. Neither feature addresses the airborne route that requires negative pressure and an N95 respirator to be controlled effectively. Airborne precautions are the highest tier of respiratory isolation, designed for pathogens that travel on tiny droplet nuclei small enough to remain suspended in the air for hours and drift far beyond conversational range. The four classic indications are tuberculosis, measles, varicella, and disseminated zoster. These organisms spread on droplet nuclei just 1 to 5 micrometers in diameter, tiny enough to behave like dust, staying aloft on air currents and remaining infectious for hours rather than falling quickly to the floor. The two pillars of airborne precautions work together. The negative pressure room pulls air inward from the corridor, so contaminated air cannot escape into the hospital, while the fitted N95 respirator, confirmed with a seal check, protects the clinician's airways from the particles already suspended inside the room. Neither measure alone is sufficient. A negative pressure room without a respirator leaves the clinician unprotected once inside. A respirator without a negative pressure room exposes the rest of the hospital every time the door opens. Both are required, always together. When you see tuberculosis, measles, or varicella on an exam, your answer must name both the negative pressure room and the fitted N95 respirator. Recognizing that airborne precautions require this two-part pairing is exactly what the certification test rewards. Question 25. A technician examines a strip with classic sawtooth-shaped waves between QRS complexes in leads 2, 3, and AVF with an atrial rate around 300 and a regular ventricular response near 150. Which rhythm fits this pattern? Your options are A. Atrial fibrillation with rapid ventricular rate, B. Multifocal atrial tachycardia, C. Sinus tachycardia at high rate, D. Atrial flutter with 2-to-1 conduction. Which one is it? Pause the video if you need more time. The correct answer is D. Atrial flutter with 2-to-1 conduction. D is correct because atrial flutter typically has an atrial rate of 250 to 350 with sawtooth waves, and a 2-to-1 conduction ratio produces a regular ventricular rate near 150. The pattern fits classic flutter. A is wrong because atrial fibrillation is irregular and lacks the organized sawtooth waves of flutter. The regular ventricular response and discrete atrial waves rule out fibrillation as the rhythm. B is wrong because multifocal atrial tachycardia features at least 3 different P-wave morphologies and an irregular ventricular response. Sawtooth waves and a regular rate do not match the multifocal pattern. C is wrong because sinus tachycardia features normal upright P waves before every QRS rather than the sawtooth waves seen in flutter. Sinus tachycardia uses the SA node origin and has different morphology. Atrial flutter is a fast, organized atrial rhythm driven by a macro reentry circuit that loops continuously around the tricuspid valve, annulus in the right atrium. Because the circuit fires at a fixed rate, the EKG shows a perfectly regular sawtooth pattern rather than the chaotic baseline of atrial fibrillation. In the inferior leads 2 and AVF, the sawtooth flutter waves are most visible. The atria depolarize at about 250 to 350 beats per minute. But the AV node acts as a gatekeeper and only passes a fraction of those impulses to the ventricles. 3 findings together confirm atrial flutter. First, rapid sawtooth flutter waves at roughly 300 per minute in the inferior leads. Second, a regular or regularly irregular ventricular response set by the conduction ratio. Third, narrow QRS complexes, because once an impulse crosses the AV node, it conducts normally through the His-Purkinje system. The ventricular rate depends entirely on the conduction ratio. A 2-to-1 ratio at an atrial rate of 300 produces the classic ventricular rate of 150 XAM, the most recognizable flutter presentation and a rate that should always trigger a search for hidden sawtooth waves before labeling the rhythm as plain supraventricular tachycardia. Any regular narrow QRS tachycardia at 150 in an adult deserves a careful look at the baseline in leads 2 and AVF. Seeing sawtooth flutter waves between each QRS, especially 2 per cycle, confirms atrial flutter with 2-to-1 conduction and changes the clinical workup entirely. Question 26. A technician walks into the EKG room and greets a new patient who looks anxious. The technician wants to project warmth and competence without leaning on jargon. Which approach best reflects effective verbal communication during a first patient encounter? Your options are A. Open with a long medical history, B. Use medical jargon to sound expert, C. Speak clearly, calmly, and plain language, D. Avoid all eye contact for privacy. Take a second. Which answer would you pick? The correct answer is C. Speak clearly, calmly, and plain language. C is correct because clear, calm speech in plain language helps an anxious patient feel oriented and trust the technician quickly. Tone, pace, and vocabulary together carry as much meaning as the words themselves during the first moments of an encounter. A is wrong because opening with a long history detour distracts from the moment the patient needs orientation about what is about to happen. History gathering belongs to the clinician's visit, not the technician's introduction. B is wrong because medical jargon makes the patient feel excluded from the conversation and adds anxiety rather than reducing it. Sounding expert is less helpful than sounding understandable to a patient meeting a new technician. D is wrong because avoiding all eye contact reads as cold and disengaged, which heightens anxiety rather than easing it. Eye contact is a basic non-verbal cue that builds connection and signals attention to the patient. Anxiety sharpens every cue a patient picks up the moment a technician walks in. The greeting isn't social small talk. It's a clinical tool that shapes the patient's physiology and the quality of the recording that follows. Effective patient communication rests on 4 habits: clear speech, calm pacing, plain language, and visible attentiveness. None require specialized training, but all 4 can be undermined by jargon, a rushed tone, or distracted body language. When a technician says sticky pads on your chest to record your heart's rhythm, the patient walks through. When she hears precordial lead placement for a 12-lead acquisition, the door slams shut. Inclusion is the goal, not accuracy of terminology. A tense patient breathes faster and tightens muscles, and that shows up directly on the EKG as artifact. The greeting a technician chooses has a measurable effect on the tracing itself. Plain language produces a calmer patient and a cleaner recording. Exam writers test the contrast between jargon and plain language specifically because students confuse technical vocabulary with clinical authority. The competent technician defaults to plain words every encounter, and patients read that ability as confidence, not weakness. Question 27. A technician learns about the plateau phase of the ventricular action potential, which sustains depolarization long enough to trigger contraction. She wants to identify the ions most responsible for the plateau phase. Which ion movement sustains the plateau? Your options are A. Calcium influx balanced by potassium efflux. B. Sodium influx with no efflux. C. Only chloride influx during this time. D. Sodium efflux through gated channels. Before I reveal it, which one do you think is right? The correct answer is A. Calcium influx balanced by potassium efflux. A is correct because the plateau phase of the ventricular action potential is sustained by calcium influx through L-type calcium channels, balanced by potassium efflux. This stable depolarization period triggers calcium-induced calcium release that drives myocyte contraction. B is wrong because sodium influx without efflux is the pattern of phase 0, not the plateau phase. The plateau phase is no longer driven by sodium currents after the fast channels close. C is wrong because chloride influx does not predominate during the cardiac plateau phase, and chloride movements are minor in this context. The plateau is dominated by calcium movements paired with potassium currents. D is wrong because sodium efflux through gated channels is not the mechanism that maintains the plateau. The plateau depends on inward calcium and outward potassium balancing each other, not on sodium movement out. The plateau phase is the long flat segment of the ventricular action potential. Phase 2, that separates depolarization from repolarization. It lasts roughly 150 to 200 milliseconds, and it is what makes cardiac muscle fundamentally different from skeletal muscle. During phase 2, 2 ion currents balance each other. Calcium flows in through slow L-type calcium channels, while potassium flows out through delayed rectifier potassium channels. Because these inward and outward currents are roughly equal, the net current is near 0 and the membrane voltage holds steady near 0 millivolts. The plateau keeps the cell electrically active long enough for the entering calcium to trigger a much larger calcium release from the sarcoplasmic reticulum. That calcium drives contraction of the contractile proteins. Without the plateau, the cell would repolarize before a full contraction could develop, and stroke volume would be inadequate. The plateau is a balance, not a single current. Fast sodium channels have already inactivated by the time phase 2 begins, so sodium plays no role here. Naming only calcium influx is incomplete. Las vanwitafate, without potassium efflux opposing it, the voltage would not remain flat. As L-type calcium channels gradually inactivate, potassium efflux dominates and repolarization begins. Remember, the cardiac plateau is produced by inward calcium current paired with outward potassium current, disrupting either with calcium channel blockers or potassium channel blockers. Changes the shape and duration of the action potential in predictable ways. Question 28. A patient asked the technician to keep a small religious object on a thin cord around her neck during her resting EKG because removing it for any reason feels deeply distressing. The cord is not crossing any electrode site. What is the best response? Your options are A. Remove the object firmly without asking. B. Leave the object in place and proceed. C. Cancel the test until the family arrives. D. Place electrodes directly on top of it. What's your answer? Commit to one before I continue. The correct answer is B. Leave the object in place and proceed. B is correct because respecting cultural and religious practices is part of patient-centered care, and the object does not interfere with any electrode placement. Leaving it where it is allows the test to proceed with full respect for the patient's preferences and beliefs. A is wrong because firmly removing a religious item without asking dismisses the patient's beliefs and may cause distress during what should be a calm test. Respect for religion and dignity is built into the basic ethical standards. C is wrong because cancelling a clinically indicated test over a small object that interferes with nothing wastes time and may delay care. There is no clinical justification to involve family for a routine recording the patient consents to. D is wrong because placing electrodes on top of any object disrupts the jaw-to-skin contact and produces artifacts in those leads. The signal becomes unreliable, so the workaround would hurt the diagnostic value of the recording. When patients wear religious objects during an EKG, the technician's job isn't simply to remove everything, it's to evaluate whether the object actually affects the recording. Respecting a patient's religious practice is part of the standard of care, not an exception to it. EKG electrodes detect millivolt level cardiac signals, so any metal sitting directly on a recording site can cause artifact. A small metal worn high on the neck sits well above the chest electrode positions, meaning it contacts no recording site and introduces no interference. In practice, the decision comes down to 3 quick steps. Visually check where the object sits, assess whether it contacts any electrode site, and honor the patient's preference about moving it. If no contact exists, the object stays in place and the test proceeds. The removal jewelry policy is general guidance, not an absolute rule. A competent technician reads the specific situation. If the object doesn't touch a recording site, it stays. If it does, the technician asks the patient to tuck it aside, still worn. The patient's wishes always take precedence over a rigid default. The exam rewards technicians who evaluate each situation individually. A small religious object that doesn't contact any electrode site should be left in place. Clean recording and patient respect are not in conflict. Question 29. A technician witnesses a patient develop a hypertensive crisis during stress testing, with blood pressure rising above 250 over 120. The supervising clinician is paged. What is the technician's appropriate next action while waiting for the clinician? Your options are A. Independently administer an antihypertensive. B. Continue the stress test to peak exercise. C. Ignore the reading as a false alarm. D. Stop the test, observe, and notify the clinician. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Stop the test, observe, and notify the clinician. D is correct because the appropriate response is to stop the test, observe the patient, and notify the supervising clinician for medication or further direction. Blood pressure often falls promptly with rest, but the technician does not administer antihypertensives independently. A is wrong because administering antihypertensives is outside the technician's scope of practice. Medication decisions during a hypertensive crisis belong to the supervising clinician with appropriate orders. B is wrong because continuing to peak exercise during a hypertensive crisis dangerously increases the cardiac load on an already stressed system. Continuing the test could trigger a stroke or other vascular event. C is wrong because dismissing a high blood pressure reading as a false alarm without verification risks missing a real emergency. The reading must be evaluated, not ignored, even if the cuff size or technique might be at fault. When a patient's blood pressure climbs to dangerous level during exercise stress testing, the response must be immediate and precise. Understanding the thresholds and the correct sequence of actions is essential for any cardiac technician. The American Heart Association defines specific termination thresholds. The key numbers are a systolic above 250 or a diastolic above 115 to 120. Severe symptoms, significant arrhythmias, and ST changes are among the other official stop criteria. The correct response follows 3 coordinated steps. Stop the test immediately. Transition the patient to a seated or supine recovery position, and notify the supervising clinician without delay. During recovery, EKG and blood pressure are monitored every 1 to 2 minutes. Picture a patient mid-protocol when the monitor shows 260 over 130. That single reading crosses both thresholds simultaneously, making the stop decision immediate and non-negotiable. Continuing the test at this point risks hypertensive emergency, stroke, or aortic dissection. Stopping is not a failure. It is the protocol working exactly as designed. Recognizing the threshold and executing the response correctly is what the certification exam tests and what protects real patients every day. Question 30. During a routine EKG, the patient begins to describe feeling vague chest pressure that comes and goes. The technician nods, leans slightly forward, and rephrases what the patient just said. Which therapeutic technique is the technician using here? Your options are A. Paraphrasing the patient's words. B. Offering a personal anecdote. C. Changing the subject quickly. D. Ignoring the patient's report. Which would you go with? Lock it in before the reveal. The correct answer is A. Paraphrasing the patient's words. A is correct because paraphrasing involves restating the patient's message in the technician's own words to confirm understanding and signal active listening. The patient hears that the message landed, which encourages more disclosure during the encounter. B is wrong because personal anecdotes shift the focus to the technician's own experiences and pull the conversation away from what the patient is reporting. The patient needs to be heard, not redirected to someone else's story. C is wrong because abrupt topic changes signal that the original concern was not taken seriously and may stop disclosure mid-sentence. Patients often clam up when the listener moves on before the message has been acknowledged. D is wrong because ignoring a chest-related report from a patient on the table risks missing a clinically important symptom. Failure to acknowledge also breaks the therapeutic relationship and discourages further reporting during the test. Active listening is a structured technique where the listener mirrors both the content and emotion of what a patient says. The goal is to confirm understanding and keep the conversation open for refinement. When you paraphrase, you restate the patient's words in slightly fresh language. This confirms to the patient that they were heard, and it opens a moment for either party to catch and correct any misunderstanding before it compounds. In practice, body language and verbal technique work together. Eye contact establishes attention, leaning forward signals interest, and open posture reduces judgment. The technician then uses a reflective opener to introduce the paraphrase and closes with a soft confirmation question. Paraphrasing is often confused with techniques that look similar but do different things. Verbatim repetition shows no processing. Closed questions narrow the conversation. Direct advice ends the patient's exploration. Only paraphrasing demonstrates understanding while still leaving room for the patient to refine. Think of paraphrasing as the careful middle path. It stays close to the patient's words without simply echoing them, and it never adds clinical interpretation beyond what the patient actually said. That balance is exactly what exam scenarios are testing. Question 31. A technician examines a strip and notices each P wave is followed by a QRS, but the PR interval lengthens progressively across several beats until one P wave fails to conduct and the QRS is dropped. Then the pattern repeats. Which block fits? Your options are A. First degree AV block constant interval, B. Mobitz type 1 second degree block, C. Mobitz type 2 second degree block, D. Third degree complete AV block. Don't overthink it. Which one feels right? The correct answer is B. Mobitz type 1 second degree block. B is correct because progressively lengthening PR intervals followed by a dropped QRS describes Mobitz type 1 second degree AV block, also called Wenkebach. The classic teaching is longer, 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 drop, then you have a Wenkebach. A is wrong because first degree AV block has a constant prolonged PR interval with every beat conducted, not progressive lengthening with dropped beats. The two blocks have different patterns and different prognoses. C is wrong because Mobitz type 2 block has a constant PR interval for conducted beats with sudden dropped beats, not progressive lengthening. The two Mobitz patterns differ in whether the PR varies before the drop. D is wrong because third degree complete AV block features atrial and ventricular activity that are completely dissociated with no conducted relationship. A pattern that resets after a drop is not complete block. Mobitz type 1 second degree AV block, known as Wenkebach block, is one of the most recognizable rhythm patterns in cardiology. Understanding why it happens and how to spot it on a tracing is essential for any certification exam. On the tracing, the PR interval stretches a little longer with each successive beat until one P wave finds the AV node too fatigued to conduct at all. That non-conducted P wave produces a brief pause, after which the node recovers and the next PR interval resets to its shortest value, starting the cycle over. Every Wenkebach cycle is defined by three features together. The PR interval lengthens across consecutive beats. A P wave eventually appears without a following QRS producing a pause, and then the PR interval resets to its shortest value on the very next conducted beat. The critical distinction is between Mobitz type 1 and Mobitz type 2. Type 1 shows progressive PR lengthening with a block at the AV node and a generally benign clinical course. Type 2 has constant PR intervals on conducted beats. The block sits below the AV node in the His-Purkinje system, and it carries a much higher risk of progressing to complete heart block. When you see a rhythm with grouped beating and a PR that stretches longer, beat by beat before a dropped QRS, that pattern locks in Mobitz type 1. Hold that rule, lengthening before the drop, and you will call every second-degree block correctly. Question 32. A technician applies a pulse oximeter to an adult patient before a stress test and obtains a reading of 93%. The patient is breathing comfortably with no chronic lung disease history on the chart. Which interpretation fits the saturation finding? Your options are A. Normal oxygen saturation reading, B. Severe hypoxemia requiring intervention, C. Carbon monoxide poisoning confirmed, D. Mild hypoxemia worth reporting. Got a guess? Lock it in. The correct answer is D. Mild hypoxemia worth reporting. D is correct because a reading between 91 and 94% is classified as mild hypoxemia and is worth reporting to the clinician before proceeding with stress testing. The finding may reflect equipment, technique, or a real respiratory issue that needs review. A is wrong because normal oxygen saturation falls between 95 and 100% on standard pulse oximetry. The reading described sits below that range and therefore does not meet the normal saturation criteria. B is wrong because severe hypoxemia is defined by saturations of 85% or below and would typically present with marked distress. The reading in question is not nearly that low and does not meet the severe threshold. C is wrong because carbon monoxide poisoning produces a falsely normal pulse oximetry reading rather than a clearly low one. The drop to 93% does not match the typical misleadingly high oximetry pattern seen with carbon monoxide exposure. Pulse oximetry estimates how much of your hemoglobin is carrying oxygen using two wavelengths of light passed through a fingertip or earlobe. Understanding what the numbers mean and when they matter so is the core skill here. In a healthy adult breathing room air, 95 to 100% is normal and requires no action. A reading of 93% falls below that cutoff and represents mild hypoxemia. Below 90%, the oxyhemoglobin dissociation curve becomes steeper, meaning small pressure drops cause large saturation drops. The oxyhemoglobin dissociation curve explains why 93% is concerning but not emergent. That saturation corresponds to a PaO2 of roughly 68 millimeters of mercury, below the normal 80 to 100 range, but not yet in the steep portion where a small pressure drop causes a dramatic saturation collapse. When a stable reading of 93% is obtained, the technician first confirms proplacement and signal quality, then assesses the patient for cough, dyspnea, or unrecognized lung disease. With a clean reading and no clear explanation, the correct step is to report the finding to the supervising clinician before proceeding. The critical distinction is this: 95% and above needs no comment, but 93% before a procedure that increases oxygen demand requires a verbal report to the clinician. It is a soft signal, not an emergency, not normal, and the right move is always to communicate upward. Question 33. A technician sees a sharp pacing spike on a tracing followed by no subsequent depolarization wave from the chamber the pacemaker is trying to activate. The pacemaker fired, but the heart did not respond. Which pacemaker malfunction does this pattern represent on the strip? Your options are A. Successful capture with normal function, B. Magnet mode activation manually, C. Failure to capture by the device, D. Oversensing of cardiac signals. Which one is it? Pause the video if you need more time. The correct answer is C. Failure to capture by the device. C is correct because failure to capture appears as a pacing spike with no subsequent depolarization wave because the impulse failed to trigger the chamber it was meant to activate. Causes include lead displacement, lead tip fibrosis, low battery, or electrolyte issues. A is wrong because successful capture produces a depolarization wave immediately following the spike. The absence of any wave after the spike rules out normal function in the scenario. B is wrong because magnet mode causes asynchronous pacing at a fixed rate and is used to test the device. Magnet activation does not by itself cause spikes without responses. D is wrong because oversensing causes the pacemaker to inhibit firing when it should pace, producing absent spikes rather than spikes with no response. The two malfunctions have different appearances entirely. When a pacemaker fires but the heart doesn't respond, we call that failure to capture. Understanding why this happens and how to spot it requires knowing how pacemakers normally work. Capture means the pacemaker's delivered current successfully triggers an action potential in the surrounding cells. Failure to capture occurs when that current isn't enough, due to a dislodged lead, fibrotic scarring around the tip, hyperkalemia, or a depleted battery. On the tracing, failure to capture looks like a pacing spike sitting alone on the baseline with no QRS complex following. A normally captured ventricular spike is immediately followed by a wide QRS. When that QRS is absent, the spike was not effective. Exam questions hinge on distinguishing four malfunction modes. Failure to capture has spikes but no response. Failure to sense produces extra spikes on native beats. Failure to pace means no spike appears at all, and oversensing causes spikes to be incorrectly withheld. The key discriminator is always which element is missing or extra. A visible pacing spike with no following QRS, or no P wave for atrial pacing, is the defining signature of failure to capture every time. Question 34. A technician examines the rapid spread of the electrical impulse through the ventricles after the bundle of his and bundle branches. She wants to identify the terminal fibers that deliver the impulse to the working ventricular myocardium. Which fibers complete the ventricular conduction system? Your options are A. The Purkinje fibers in the ventricles, B. The Bachmann's bundle in the atria, C. The chordae tendineae below the valves, D. The coronary sinus drainage system. Take a second. Which answer would you pick? The correct answer is A. The Purkinje fibers in the ventricles. A is correct because the Purkinje fibers are the terminal conduction fibers that distribute the electrical impulse throughout the ventricular myocardium for coordinated contraction. Their rapid conduction allows both ventricles to depolarize nearly simultaneously and pump together. B is wrong because Bachmann's bundle is an interatrial conduction pathway that carries the impulse from the right atrium to the left atrium. Bachmann's bundle is an atrial structure rather than a terminal ventricular conductor. C is wrong because the chordae tendineae are mechanical structures that anchor the atrioventricular valve leaflets to the papillary muscles. They have no role in electrical conduction within the heart at all. D is wrong because the coronary sinus is a venous drainage channel that returns blood from the heart muscle to the right atrium. It is a vascular structure rather than part of the electrical conduction system. The Purkinje fibers are the final link in the cardiac conduction system, responsible for delivering the electrical impulse rapidly and simultaneously across the ventricular walls. Understanding their precise role and position in the sequence is the key to answering conduction system questions correctly. The impulse follows a strict sequence. It originates at the sinoatrial node, passes through the atrioventricular node, where a deliberate delay occurs, then travels through the bundle of his and splits into the right and left bundle branches before finally entering the Purkinje network. The bundle branches taper into a fine tree of Purkinje fibers that fan across the inner surface of both ventricles. These fibers dive into the myocardium at many points simultaneously, achieving rapid, coordinated ventricular depolarization, completing the narrow QRS complex seen on the EKG. Purkinje fibers conduct at 2 to 4 meters per second, among the fastest in the heart. They sit downstream of the bundle branches and upstream of the working ventricular myocytes, making them the last specialized conducting structures. Without this network, ventricular depolarization would be slow, uneven, and inefficient. When an exam question asks where rapid ventricular spread occurs, the precise answer is always the Purkinje network, downstream of the bundle branches, upstream of the working muscle, and the final handoff before contraction begins. Question 35. A technician studies the cardiac cycle and learns that one full cycle has both contraction and relaxation phases. At a resting heart rate of about 75 beats per minute, she wants to estimate how long a complete cycle lasts. About how long does one cycle take at that rate? Your options are A, about 3.2 seconds, B, about 2 seconds total, C, about 1.5 seconds, D, about 0.8 seconds. Before I reveal it, which one do you think is right? The correct answer is D, about 0.8 seconds. D is correct because at a resting heart rate near 75 beats per minute, one full cardiac cycle takes about 0.8 seconds, with roughly 0.3 seconds in systole and 0.5 seconds in diastole. A is wrong because 3.2 seconds would correspond to roughly 19 beats per minute, far below any physiologic resting rate. The number is off by a factor that places it well outside normal cardiac physiology. B is wrong because 2 seconds per cycle would correspond to roughly 30 beats per minute, a profound bradycardia inconsistent with a resting rate of 75. The number is inconsistent with the stated heart rate. C is wrong because 1.5 seconds per cycle would correspond to about 40 beats per minute, slower than the resting rate described. Cycle length and heart rate are inverse, and this option mismatches them. Every heartbeat follows a complete cardiac cycle, one full sequence of contraction and relaxation. Understanding how long that cycle lasts and why is the foundation of reading any rhythm strip correctly. On a standard EKG strip running at 25 millimeters per second, one large box equals 0.2 seconds. At a resting heart rate of 75, 4 large boxes span the entire R to R interval. That is your cycle length of 0.8 seconds. Readable directly off the strip. The relationship is an inverse 1. Cycle length in seconds equals 60 divided by heart rate. At 60 beats per minute, the cycle is 1 full second. At 75, the canonical resting rate, it is 0.8 seconds. At 100, it shortens to 0.6. Within the 0.8 second cycle, systole takes roughly 1/3 and diastole 2/3. When heart rate climbs, diastole bears the bigger cut. Above 150 beats per minute, the ventricles cannot fill completely, stroke volume drops, and fast rate actually hurts cardiac output. Keep the conversion simple, 60 divided by the rate. Know the 3 canonical answers, 1 second, 0.8, and 0.6, and you will never lose points on a cycle length question. Question 36. A technician examines a patient's tracing and finds prominent changes in leads 1, AVL, V5, and V6. She maps this lead group to a specific wall of the heart. Which wall do these leads collectively view? Your options are A, the lateral wall of the left ventricle, B, the septal wall of the heart, C, the inferior wall via diaphragm, D, the right ventricular free wall. What's your answer? Commit to one before I continue. The correct answer is A, the lateral wall of the left ventricle. A is correct because leads 1, AVL, V5 and V6 together view the lateral wall of the left ventricle. The combination of high lateral leads from the limb side and low lateral leads from the precordials covers the wall. B is wrong because the septal wall is viewed primarily by leads V1 and V2, which sit closest to the interventricular septum. The septal view does not extend to the high lateral or far lateral leads in this group. C is wrong because the inferior wall is viewed by leads 2, 3, and AVF and corresponds to the diaphragmatic surface of the heart. Inferior leads are limb leads in a different orientation than the lateral group. D is wrong because the right ventricular free wall is best evaluated with right-sided precordial leads, particularly V4R. Standard left-sided lateral leads do not provide a useful view of the right ventricle. The 12-lead EKG acts like a directional camera, with each lead viewing the heart from a specific anatomic angle. Understanding which leads view the lateral wall is essential for localizing pathology quickly and accurately. The lateral wall is covered by 4 leads working as a group. Lead I and AVL are the high lateral leads, viewing the upper portion from the left arm direction. V5 and V6 are the low lateral leads, positioned along the left side of the chest to capture the lower portion of the lateral wall. Together, these 4 leads form a converging view. Lead I and AVL look from above, while V5 and V6 look from the side. When findings appear across all 4 simultaneously, they point to a single anatomic region, the lateral wall of the left ventricle, most often supplied by the circumflex coronary artery. When any of these abnormalities, ST elevation, ST depression, T-wave inversion, or pathological Q waves, appear together across the lateral lead group, the underlying cause is localized to the lateral wall. The convergence across multiple leads is what confirms the regional diagnosis. The exam tests these groups because each wall has a dedicated lead set. Memorize leads as anatomic groups, not in isolation, and you will correctly localize every regional EKG pattern. The lateral mapping with lead Y, AVL, FAM, and V6 is one of the most frequently tested pairings on certification exams. Question 37. A technician finishes an EKG on a patient in contact precautions and prepares to remove her PPE in the anteroom. She wants to minimize the chance of contaminating her skin and face during the removal. Which item should be removed first in the doffing sequence? Your options are A, the mask before any other item, B, the gown before the gloves, C, the gloves as the first item, D, the goggles before any other item. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C, the gloves as the first item. C is correct because gloves are typically the most contaminated item from direct patient contact and equipment handling. So removing them first reduces the chance of transferring organisms to other layers or skin. Glove removal uses a glove-to-glove and skin-to-skin technique. A is wrong because the mask is removed near the end of the doffing sequence to keep facial protection in place during the steps that risk contamination. Pulling the mask off first exposes the face during the dirtiest removal actions. B is wrong because removing the gown while gloves are still on means the gloves contact the gown, ties, and outer surface during the motion. Glove removal must come first so the hands are no longer the dirtiest layer. D is wrong because goggles are not the most contaminated item and are typically removed later by handling only the strap. Pulling goggles first skips over gloves, which are the priority for early removal in proper order. When removing personal protective equipment after a contact precautions visit, the order you take things off is just as important as putting them on. Doffing follows a deliberate sequence based on one core principle: remove the dirtiest item first. Contamination on PPE is not uniform. Gloves carry the highest microbial load because they contact the patient directly. The gown carries a moderate load on its outer surface. Eye protection is variable, and the mask carries the lowest load. The CDC sequence moves from dirtiest to cleanest. Gloves come off first using an inside-out technique, followed by hand hygiene, then the gown, eye protection, and finally the mask. Hand hygiene is performed between high-risk steps throughout. Think of doffing like peeling an onion from the outside in. The outermost, dirtiest layer comes off first so it never drags across the cleaner layers beneath. And your face, the most vulnerable target, is protected until the very end. On the certification exam, any doffing question is answered by the same principle. Contamination level drives the order. Gloves come off first because they are the dirtiest. Know that, and every PPE removal scenario becomes straightforward. Question 38. A technician needs to alert a nurse that a patient on telemetry just developed a new irregular rhythm with associated lightheadedness. She wants to communicate efficiently. Which professional on the multidisciplinary team is the most direct first contact for this kind of clinical change? Your options are A. The pharmacy team on call, B. The respiratory therapist on duty, C. The unit secretary at the desk, D. The patient's assigned registered nurse. Which would you go with? Lock it in before the reveal. The correct answer is D. The patient's assigned registered nurse. D is correct because the assigned registered nurse is the most direct contact for a clinical change because she carries direct care responsibility and can assess, escalate, and intervene immediately. Direct nurse contact keeps the chain of communication tight. A is wrong because the pharmacy team manages medications and dosing rather than acute rhythm changes at the bedside. Pharmacy involvement comes later if a medication is ordered, not first when an arrhythmia appears on the monitor. B is wrong because the respiratory therapist focuses on ventilation, oxygen, and airway management rather than rhythm interpretation and immediate intervention. Respiratory specialists join when breathing problems arise, not at the first sign of an arrhythmia. C is wrong because the unit secretary handles communication, scheduling, and paperwork at the central desk. Clinical changes need a clinician's hands and judgment, which sit outside the secretary's role even when the desk is the closest physical contact. When an EKG technician identifies a new arrhythmia, knowing exactly who to tell first is not a matter of convenience. It is a matter of patient safety. Hospital care is built around assigned responsibility, and that structure shapes every clinical communication decision. The patient's assigned registered nurse is the correct first recipient because she holds three things: current knowledge of the patient, the authority to act, and the ability to escalate. No other role on the unit combines all three. The technician delivers the finding using SPAR, situation, background, assessment, and recommendation, packaged in a few clear sentences. She then confirms the nurse received the message with a brief readback before stepping away. The covering physician is the next step up, but is typically contacted by the nurse, not the technician. The unit clerk handles administrative tasks only. The family member is not an appropriate recipient for clinical information unless HIPAA permissions explicitly allow it. Whenever you see the words telemetry alert, new finding, or assigned RN on your certification exam, the answer points to the same place. Find the assigned nurse, deliver the message clearly, and confirm she heard it. That chain protects the patient and keeps the care team aligned. Question 39. A technician notices that her patient's tracing shows fine jagged baseline oscillations on multiple leads, while the patient reports feeling cold and is visibly shivering. The technician wants to address the root cause. What action best targets this artifact? Your options are A. Warm the patient and reassure for relaxation. B. Increase the gain to clarify the tracing. C. Disconnect the AC filter completely. D. Ignore the artifact and complete the test. Don't overthink it. Which one feels right? The correct answer is A. Warm the patient and reassure for relaxation. A is correct because somatic tremor artifact from shivering is best addressed by warming the patient with a blanket and reassuring them to reduce both temperature, stress, and anxiety. Once the muscles relax, the baseline cleans up and the tracing becomes interpretable. B is wrong because increasing the gain amplifies both the artifact and the genuine cardiac signal, which does not improve readability. Higher gain makes the tracing busier rather than clearer in the presence of artifact. C is wrong because disconnecting the AC filter affects a different kind of artifact entirely and does nothing for tremor caused by shivering. The two filters target different frequency ranges and noise sources. D is wrong because ignoring a heavy artifact pattern produces a tracing that the cardiologist cannot interpret reliably. Submitting a heavily contaminated tracing wastes both the technician's and the interpreter's time. Tremor artifact appears as fine, fast, jagged oscillations overlaid on the EKG baseline. This happens because EKG amplifiers pick up skeletal muscle electrical activity alongside cardiac signals, and when muscles fire repetitively, they bury the cardiac waveform under what looks like static. The artifact is not equipment noise. It is real electrical activity from the patient's own muscles. Skeletal muscles in the chest, arms, or trunk contract at tremor frequency, typically 5 to 10 cycles per second, and the electrode records both signals at once. The most common cause in a clinical setting is shivering from cold or anxiety. Less commonly, the source is a movement disorder such as Parkinson's disease or essential tremor. Identifying the cause is essential because each one has a different fix. Troubleshooting follows a strict hierarchy: patient first, electrode contact, second, equipment third. For a cold, shivering patient, the correct first move is warming E. A blanket, a warmer room, a few minutes to relax. Filters distort the cardiac signal and are never the preferred first step. The exam tests whether you reach for the clinical fix before the technical one. Shivering means warming. A movement disorder means positioning support and calm reassurance. Address the source of muscle contraction first, and the artifact resolves on its own. Question 40. A technician sees a strip with rate 180, regular narrow QRS, with P waves either not visible or buried in the preceding T waves. The patient is conscious and reports palpitations. Which rhythm fits this picture? Your options are A. Atrial fibrillation with rapid response. B. Sinus tachycardia from exercise. C. Ventricular tachycardia with pulse. D. Supraventricular tachycardia or PSVT. Got a guess? Lock it in. The correct answer is D. Supraventricular tachycardia or PSVT. D is correct because a regular narrow complex tachycardia at 180 with absent or buried P waves is typical of supraventricular tachycardia, often paroxysmal SVT from AV nodal re-entry. Treatment may include vagal maneuvers, adenosine, or cardioversion if unstable. A is wrong because atrial fibrillation is irregular rather than regular at this rate. The regular pattern described rules out fibrillation as the underlying rhythm. B is wrong because sinus tachycardia typically has visible P waves before every QRT and rates that gradually rise with stimulus. SVT often appears suddenly and lacks visible P waves due to AV nodal reentry circuits. C is wrong because ventricular tachycardia produces wide complex tachycardia rather than the narrow QRS described. The narrow complex rules out ventricular origin for the tachycardia. Supraventricular tachycardia, or SVT, is a fast, regular rhythm originating above the ventricles. Understanding its three defining ECG features is the key to identifying it correctly every time. SVT is recognized by three findings together: a fast, regular rate between 150 and 250 beats per minute, narrow QRS complexes under 120 milliseconds, and P waves that are either buried in the preceding T wave or invisible at normal positions. The most common cause of SVT is a re-entry circuit within or near the AV node. In AVNRT, the impulse loops continuously through the AV node, firing the ventricles rapidly via the HIPAA system and producing that characteristic narrow QRS. Keeping SVT distinct from other fast rhythms is where exams test you. Sinus tachycardia has clear P waves before each QRS. Atrial flutter shows sawtooth waves with a ventricular rate near 150. Ventricular tachycardia has a wide QRS. SVT alone combines fast, regular, and narrow with no visible P waves. When you see a fast, regular, narrow, complex rhythm with absent or hidden P waves, that cluster of findings is the signature of SVT. Lock in all three criteria together and you will call it correctly on every scenario. Question 41. A technician is preparing to perform an EKG on a pediatric patient and recalls that pediatric protocols often add a specific lead to the standard set. The right ventricle is more prominent in young children compared to adults. Which lead is often added in pediatric EKGs? Your options are A. The Lewis lead for P wave enhancement. B. Lead AVR doubled with extra placement. C. V3R or V4R for right ventricular view. D. Posterior lead V9 routinely added. Which one is it? Pause the video if you need more time. The correct answer is C. V3R or V4R for right ventricular view. C is correct because pediatric EKG protocols often add V3R or V4R to the standard precordial set because the right ventricle is more prominent in young children. These additional right-sided views provide better evaluation of the pediatric right ventricle. A is wrong because the Lewis lead is used to enhance P-wave visibility in adults with suspected atrial arrhythmias, not as a routine pediatric addition. Pediatric protocols address ventricular evaluation rather than atrial enhancement. B is wrong because doubling AVR with extra placement does not exist as a standard adjustment in any EKG protocol. The pediatric adjustment uses right-sided precordial leads, not duplicated augmented leads. D is wrong because posterior lead V9 is reserved for suspected posterior wall MR rather than routine pediatric use. Pediatric additions look at the right ventricle, not the posterior wall. In pediatric EKG practice, the standard 12-lead configuration gets an important addition: right-sided precordial leads, specifically V3R and V4R. Understanding why requires looking at how the developing heart differs from the adult heart. At birth, right ventricular pressure nearly equals left ventricular pressure, so the right ventricle dominates the electrical vector. The standard left-sided chest leads miss much of this contribution. Right-sided leads V3R and V4R place an electrode directly over the right ventricle, recovering the diagnostic information that would otherwise be lost. Placement mirrors the left-sided precordial geometry. V4R sits in the fifth intercostal space at the right mid-clavicular line, the exact mirror image of V4. V3R falls halfway between V1 and V4. The same horizontal reference level used for the standard leads applies on the right side, so the additional leads integrate cleanly with the rest of the tracing. This dominance is not permanent. As pulmonary vascular resistance falls during the first months and years of life, the left ventricle gradually takes over as the dominant chamber and the precordial vector shifts leftward toward the adult pattern. During the transition period, and whenever right-sided disease is suspected, The right-sided lead gives the cardiologist a direct view of the right ventricle. When an exam question mentions a pediatric protocol, right ventricular dominance, or an infant or child with suspected cardiac disease, the answer targets V3R or V4R, not posterior leads, not extra left-sided leads. The developing heart demands a specific addition, and recognizing that keeps the call correct on every age-specific scenario. Question 42. An adolescent patient with a non-English speaking parent presents for an EKG. The teenage patient speaks English well and offers to translate the technician's instructions to her own mother before signing the consent paperwork. What should the technician do? Your options are: A. Allow the teenager to translate. B. Skip the consent step entirely. C. Use a co-worker who speaks the language. D. Request a qualified medical interpreter. Take a second. Which answer would you pick? The correct answer is D. Request a qualified medical interpreter. D is correct because qualified medical interpreters reduce errors, protect family dynamics, and meet the legal duty to communicate clearly with patients of limited English proficiency. A family member, especially a child, is generally avoided when accuracy and impartiality matter. A is wrong because using a teenager to translate places a child in the middle of a parent's medical decision and risks softened or filtered language about clinical risks. Family translators also have no training in medical terminology or boundaries. B is wrong because skipping consent paperwork removes the legal documentation that the procedure was authorized. The communication barrier must be solved, not avoided, since the parent still has the right to understand what the test involves. C is wrong because an untrained co-worker who happens to speak the language has no certification in medical interpretation and may mistranslate technical terms. Convenient bilingual staff cannot stand in for an interpreter trained to handle clinical accuracy. When a patient has limited English proficiency, hospitals are legally required to provide a qualified medical interpreter, not just anyone who happens to speak the language. This obligation comes from two specific federal laws: Title 6 of the Civil Rights Act and Section 57 of the Affordable Care Act both require hospitals to provide qualified interpretation. The interpreter can be present in the room, connected by telephone, or joined via video tablet, but in every case, they must be formally trained. Using family members introduces serious risks. Children translating for parents carry emotional burdens and may filter what they say. Adult relatives often lack medical vocabulary in either language, may have conflicts of interest, and their presence can prevent patients from disclosing sensitive information freely. These failures have been linked to real adverse outcomes. In practice, the technician identifies the language need before any clinical interaction begins, then contacts the language services department. The qualified interpreter joins and facilitates communication using short, clear exchanges, speaking in the first person and conveying meaning, not just literal words. On the certification exam, any scenario involving a language barrier calls for a qualified medical interpreter. A family member, even a helpful bilingual teenager, is never the policy correct answer. Knowing the federal requirement and the rationale behind it keeps you right on every language access question. Question 43. A patient's adult daughter approaches the EKG technician in the hallway and quietly asks for an update on her father's tracing results because she lives far away and is worried. The technician has just finished the test. What should the technician do? Your options are: A. Print the tracing and hand it over. B. Quietly summarize the visible findings. C. Direct her to the ordering physician. D. Photograph the tracing and text her. Before I reveal it, which one do you think is right? The correct answer is C. Direct her to the ordering physician. C is correct because an EKG technician does not interpret results or share them with family members, even with good intentions. Sending the daughter to the ordering physician keeps the disclosure with the licensed clinician who is authorized to discuss findings. A is wrong because handing a printed tracing to a family member transfers a piece of the medical record without authorization. The technician has no order, no consent on file, and no role to make that disclosure decision. B is wrong because summarizing visible findings crosses into interpretation, which sits outside the technician's scope. Even a brief verbal description shapes the daughter's understanding in a way only a licensed clinician should be doing. D is wrong because photographing tracings on a personal device captures protected information onto unsecured technology. Sending such a photo by text adds an unencrypted transmission to the violation, layering one breach on top of another. Under HIPAA, a patient's medical information is protected, and that protection extends to what a technician can share, even with concerned family members. Let's look at why this boundary exists and how to handle it correctly. HIPAA is built on the principle that patients control their own health information. Even close adult family members are not automatically entitled to clinical results. Access requires explicit authorization from the patient, with narrow exceptions like mandatory reportable conditions. The technician's job is straightforward. Do not comment on findings, redirect the family member to the ordering physician, and keep the conversation brief and respectful. Any clinical comment, in even saying a tracing looks fine, is an unauthorized release. The ordering physician sits at the center of authorized disclosure. The technician performs the tracing and redirects any inquiries, pointing the family member toward the physician, who can verify what releases the patient has authorized before communicating results. On exam day, whenever a family member asks a technician for clinical information, the correct response is always to redirect to the ordering physician. Warm, brief, and firm keeps you within HIPAA and within your scope of practice every time. Question 44. A technician is preparing a pregnant patient in her third trimester for an EKG. The patient becomes uncomfortable lying supine and reports lightheadedness. The technician knows about aortic valve compression in late pregnancy. What position adjustment is appropriate? Your options are: A. Tilt the patient slightly to the left side. B. Continue supine despite the symptoms. C. Have the patient sit completely upright. D. Place the patient in prone position. What's your answer? Commit to one before I continue. The correct answer is A. Tilt the patient slightly to the left side. A is correct because late-term pregnancy can cause aortocaval compression in the supine position as the gravid uterus presses on the inferior vena cava. A left lateral tilt of about 15 to 30 degrees relieves the pressure and restores venous return. B is wrong because continuing supine despite the patient's symptoms ignores the aortocaval compression that is causing the lightheadedness. Letting the patient stay symptomatic creates a safety risk that has a simple positioning fix. C is wrong because sitting completely upright would alter the standard recording position more than necessary and change the EKG axis. A small left lateral tilt is the targeted adjustment for aortocaval compression rather than a full posture change. D is wrong because prone position is even less safe for a pregnant patient and impossible for chest lead access. Prone offers none of the relief that the left lateral tilt provides while making the EKG impossible. When a pregnant patient in the third trimester lies flat on her back, a predictable mechanical problem can develop. Understanding why it happens and how to fix it instantly is essential for anyone performing EKGs on pregnant patients. The inferior vena cava runs along the right side of the spine. In the third trimester, the enlarged uterus is heavy enough to compress the IVC when the patient is supine. reducing venous return to the right atrium and dropping cardiac output and blood pressure. The resulting chain reaction begins with reduced venous return, which decreases cardiac output and lowers systemic blood pressure. The patient typically notices lightheadedness and nausea, and placental perfusion can be compromised if the compression is not relieved. The intervention is simple. Place a wedge, folded blanket or pillow under the right hip, elevating it 10 to 15 degrees. This tilts the pelvis and shifts the uterus off the vena cava. Venous return improves immediately and symptoms usually resolve within 1 to 2 minutes. The key exam detail is laterality. Elevating the right hip tilts the patient to the left and moves the uterus away from the vena cava. Tilting the wrong way worsens the compression. Supine hypotension is mechanical, positional, and fixed with one simple adjustment. Question 45. A technician walks toward an isolation room with a sign reading airborne precautions and notices the door is propped open with a chair. The patient is inside on contact and airborne setup for active tuberculosis. What is the most appropriate immediate action? Your options are: A. Enter as usual and start the EKG quickly. B. Leave the door open for easier movement. C. Close the door before any further entry. D. Remove all isolation signage from the door. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Close the door before any further entry. C is correct because airborne precautions depend on negative pressure that only works when the door stays closed. So closing it before entering restores the engineered airflow. Closing the door is the immediate fix that maintains protection for staff, visitors, and other patients. A is wrong because entering without first closing the door allows infectious particles to escape into the corridor during the visit. Speed of work cannot compensate for losing the negative pressure protection while the door sits open. B is wrong because leaving the door open turns a controlled environment into an open exchange of air with public hallway space. Open doors defeat the entire engineered airflow design that the isolation room depends on for safety. D is wrong because removing the signage hides essential information from anyone walking up to the room and creates a serious safety gap. Signs warn staff and visitors about required PPE and entry rules for the room. When an airborne isolation room's door is left open, the entire containment system fails. Understanding why requires knowing how negative pressure rooms actually work. The room is held at slightly lower pressure than the surrounding corridor, sometimes just a few pascals, so air flows inward and is exhausted through a filtered vent. This inward flow prevents airborne pathogens from escaping into the hallway. The moment a door is propped open, 3 things happen in seconds. The pressure equalizes, air moves freely in both directions, and any airborne organism in the room can drift into the corridor. The first action is always to close the door. Before donning PPE, before entering to assess the patient, before calling for help. None of those steps matter if the room is still venting airborne pathogen into the unit. Only after the door is shut and the pressure gradient is restored does everything else proceed. Whenever you see the words propped open, negative pressure room, or airborne precautions, the priority is always the same. Close the door first, then everything else follows. Question 46. A technician notices a small cut on her index finger before starting her shift, and she also has natural nails painted with a dark polish that extends past her fingertips. Which of these features should she correct before performing patient care? Your options are: A. The cut only. B. The polish only. C. The long nails only. D. The cut and the long nails. Which would you go with? Lock it in before the reveal. The correct answer is D. The cut and the long nails. D is correct because open cuts must be covered and reported for both worker and patient safety, and natural nails should stay shorter than a quarter-inch to limit bacterial harbor. Both create infection control risks that must be addressed first. A is wrong because covering the cut alone leaves the nail length untouched, even though long nails harbor organism and can tear gloves during procedures. Addressing only one issue fixes only half the contamination risk the technician is carrying. B is wrong because Polish policies vary by facility. While the open cut and excessive nail length are the consistently regulated issues, treating Polish as the central problem misranks the actual hazards infection control policies prioritize most. C is wrong because trimming nails without covering the cut still leaves a portal of entry for organisms to enter the technician's bloodstream during patient care. Skin breaks are taken seriously and cannot be left exposed during clinical work. Intact skin and clean trimmed nails are the body's first line of defense against infection. In clinical settings, even small lapses in either area can create real pathways for pathogens to reach patients or clinicians. There are 4 specific hand findings that violate safe clinical practice. An open cut creates a direct portal of entry. Nails longer than a quarter-inch past the fingertip harbor significantly more bacteria. Chipped or dark polished traps organisms in microscopic crevices. And artificial nails are prohibited in most direct care settings due to their link with infection outbreaks. Intact skin physically blocks bacteria from entering the body. When that barrier is broken, even by a small cut, pathogens can bypass it entirely and access deeper tissue or the bloodstream. This is why wound coverage is required before any patient contact. Addressing hand hygiene concerns before clocking in means cleaning and covering any open wound, trimming nails to no longer than a quarter-inch beyond the fingertip, and removing any chipped or dark polish. Only after all concerns are resolved should the clinician perform hand hygiene and proceed to patients. Exam scenarios often present multiple infection control issues at once. The clinician and the test taker must identify and correct every concern before patient contact, not just the most obvious one. Catching both findings is what the question is designed to reward. Question 47. A technician sees a strip with a wide QRS, an RSR prime pattern in V1 that looks like rabbit ears, and a slurred S-wave in lead 1 and V6. The QRS duration is above 0.12 seconds. Which conduction defect fits? Your options are A. Left bundle branch block typical pattern, B. Right bundle branch block, C. Wolff-Parkinson-White syndrome, D. First degree AV block prolonged conduction. Don't overthink it. Which one feels right? The correct answer is B. Right bundle branch block. B is correct because right bundle branch block produces a wide QRS with the characteristic RSR prime pattern in V1, often called rabbit ears, and a slurred S-wave in leads 1 and V6. The pattern reflects delayed right ventricular conduction. A is wrong because left bundle branch block produces a broad notched R wave in V6 and a deep S in V1, the opposite of the right bundle branch pattern. The rabbit ears morphology in V1 specifically marks right bundle block. C is wrong because Wolff-Parkinson-White syndrome features a short PR interval and a delta wave at the start of the QRS rather than the RSR prime pattern. The conduction defects are anatomically and electrically different. D is wrong because first degree AV block involves a prolonged PR interval, not a wide QRS with RSR prime morphology. The PR and QRS measurements describe different parts of the cardiac cycle. Right bundle branch block occurs when the electrical impulse cannot travel through the right bundle branch, forcing the right ventricle to depolarize later via the slower working myocardium. This delay widens the QRS and creates a distinctive pattern on the ECG. Normally both bundle branches conduct simultaneously, making the QRS narrow. When the right branch is blocked, the impulse detours through the slower working myocardium, arriving at the right ventricle late and widening the QRS beyond 120 milliseconds. Three findings together confirm right bundle branch block. First, a wide QRS greater than 120 milliseconds. Second, an RSR prime pattern in V1. The two upward deflections resemble rabbit ears. Third, a slurred S wave in lead 1 and V6 reflecting the late rightward depolarization vector. Both bundle branch blocks share a wide QRS, but lead-specific morphology reveals which branch is blocked. Rabbit ears in V1 point to the right side, while a deep QS in V1 with a broad notched R in the lateral leads points to the left. Matching these lead patterns to the block type is exactly what the exam tests. When you see a wide QRS, go straight to V1. Rabbit ears confirm right bundle branch block. Then verify the slurred S in the lateral leads. Those three findings together lock in the diagnosis every time. Question 48. A technician learns that the normal electrical impulse of the heart starts in a specific cluster of cells in the upper right atrium near the superior vena cava. She wants to identify this pacemaker. Which structure is the primary pacemaker of the heart? Your options are A. The atrioventricular node in the lower right atrium. B. The Purkinje fibers in the ventricles. C. The sinoatrial node near the superior vena cava. D. The bundle of His in the septum. Got a guess? Lock it in. The correct answer is C. The sinoatrial node near the superior vena cava. C is correct because the sinoatrial node, located in the upper right atrium near the superior vena cava, is the heart's primary pacemaker and normally fires at 60 to 100 beats per minute. The SA node sets the pace for the conduction sequence. A is wrong because the atrioventricular node serves as a backup pacemaker at 40 to 60 beats per minute. Its role is to delay conduction and take over only when the SA node fails to fire normally. B is wrong because the Purkinje fibers and ventricular myocardium have an intrinsic rate of only 20 to 40 beats per minute and serve as the lowest tier backup. Ventricular escape rhythms are too slow to be the primary pacemaker. D is wrong because the bundle of His conducts the impulse from the AV node into the ventricles but does not normally generate the impulse itself. The bundle is a relay path rather than a pacemaker site. The sinoatrial node is the heart's natural pacemaker, the origin of every normal heartbeat. Understanding where it sits, what makes it fire, and how its signal travels is essential for mastering cardiac conduction questions. The SA node sits as a small crescent of specialized cells in the upper right atrium, just below where the superior vena cava enters the heart. This precise location is what the exam tests, not the left atrium, not the septum, not the AV junction. Say node cells have a slow inward current of sodium and calcium that gradually drifts the membrane potential upward until threshold is reached and an action potential fires. The cycle resets and repeats automatically, no external trigger required. The resting heart rate is lower than this intrinsic rate because continuous vagal tone holds it down to the 60s or 70s. The impulse leaves the SA node and spreads across the atria via 3 internodal tracts, producing the P wave. It then reaches the AV node, which delays the signal briefly, the PR interval, before it continues through the bundle of His, the bundle branches, and the Purkinje fibers to depolarize the ventricles. The key distinction to lock in: the SA node initiates the impulse from the upper right atrium near the superior vena cava, while the AV node delays it at the floor of the right atrium. Keeping these two locations and roles distinct is what separates a correct answer from a costly mix-up on every conduction origin question. Question 49. Before a routine 12-lead EKG, the technician explains what the test involves and asks the patient to lie down on the table. The patient cooperates and removes his shirt without signing a separate form. Which type of consent does the patient's cooperation reflect? Your options are A. Implied consent through cooperation, B. Express written consent requirement, C. Emergency consent without ability, D. Informed consent for surgery. Which one is it? Pause the video if you need more time. The correct answer is A. Implied consent through cooperation. A is correct because a non-invasive routine EKG generally does not require a separate written form, and the patient's voluntary cooperation in lying down and exposing the chest counts as implied consent. The cooperation itself signals agreement to a low-risk procedure. B is wrong because express written consent is reserved for higher-risk procedures with significant complications, such as surgery or invasive cardiac catheterization. A standard surface tracing does not meet the risk threshold that triggers a formal signed document. C is wrong because emergency consent is invoked when a patient cannot communicate and immediate intervention is needed to prevent harm. A routine EKG with a conversational patient lying calmly on the table has neither of those conditions present. D is wrong because informed consent for surgery is a formal process where a surgeon explains risks, benefits, alternatives, and refusal rights before a major operation. None of that applies to a brief surface recording. Consent in medicine isn't one size fits all. The type of consent required scales directly with the risk and complexity of a procedure. And for routine, low-risk interactions, implied consent through patient cooperation is both legally recognized and sufficient. Consent comes in three forms matched to procedural risk. Implied consent covers routine, low-risk procedures like a resting EKG. Verbal consent suits moderate risk situations involving significant patient choice. Written consent is required for surgery, anesthesia, and other invasive high-risk procedures. In practice, implied consent unfolds in 3 steps. The technician explains the procedure clearly. The patient demonstrates cooperation, lying down, removing clothing, raising no objection, and the technician documents in the chart that the explanation was given and cooperation was observed. No signed form is needed. Matching consent type to procedure is the core exam skill. A resting EKG, no needles, no medication, no significant risk, requires only implied consent. A stress test carrying a small cardiac risk warrants verbal consent. A cardiac catheterization being invasive with substantial risk demands written consent. The key insight to carry into the exam is simple. When a patient voluntarily cooperates with a routine, low-risk procedure like a resting EKG, that cooperation is the consent. Not every clinical interaction requires a signed form, only those where risk and complexity demand it. Question 50. A technician is asked about the brief period of atrial contraction that adds the final volume to the ventricles just before ventricular systole. She knows this contribution is sometimes called the atrial kick. About how much of resting ventricular filling does atrial contraction contribute? Your options are A. About 5% at rest, B. About 20 to 30% at rest, C. About 50% at rest, D. About 70% at rest. Take a second. Which answer would you pick? The correct answer is B. About 20 to 30% at rest. B is correct because the atrial kick contributes about 20 to 30% of ventricular filling at rest, with a larger share during exercise when filling time shortens. The remainder of filling occurs passively as ventricles relax during early and mid-diastole. A is wrong because 5% dramatically underestimates the atrial contribution to ventricular filling. Such a low number would suggest atrial kick loss has little hemodynamic effect, which contradicts the clinical importance of atrial function. C is wrong because 50% overstates the atrial contribution by roughly double. The bulk of ventricular filling actually occurs passively during early diastole, before the atrial kick adds its final share. D is wrong because 70% reverses the relative roles of passive filling and atrial contraction in the cardiac cycle. Passive filling, not atrial contraction, accounts for the majority of ventricular filling at rest. The atrial kick is the boost of blood that atrial contraction delivers to the ventricles at the very end of diastole, just before ventricular systole begins. Understanding this mechanism helps explain why atrial dysfunction has real consequences for cardiac output. During early diastole, the ventricles fill passively through the open mitral and tricuspid valves. Then, just before the QRS complex, the atria contract and push an additional bolus of blood across, topping off ventricular volume right before systole. At rest, the atrial kick contributes about 20 to 30% of total end diastolic volume. As heart rate rises and diastole shortens, passive filling decreases and the atrial kick's relative share grows. In atrial fibrillation, uncoordinated atria cannot contract effectively, so their contribution disappears entirely. When atrial fibrillation removes the coordinated atrial contraction, the ventricles lose that final volume top-off each cycle. Stroke volume falls by roughly the same 20 to 30%, and patients with limited cardiac reserve notice the drop as fatigue or reduced exercise tolerance right away. The exam critical number is 20 to 30% at rest. Anchor that range. Remember it grows when diastole shortens. And connect its loss to the clinical picture of atrial fibrillation, and you will answer every atrial physiology question with confidence.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.